Good morning. I'm welcome you all for today's webinar. One specialty of this one is we have involved all the 5 states of southern state chapters of ISAR in this webinar. That is the specialty. I request our President, Dr. Kamala Selvaraj, to give introduction and introduce the moderators for the first session.
I'm delighted to invite all of you for the 7th webinar, Regional ECME on Assisted Reproductive Technology, conducted by TOG. I'd like to, of course, thank Dr. Sanjeev Reddy for his ever-ending enthusiasm to conduct webinars continuously and feed the latest information to one and all. My duty today is going to be to introduce the moderator for the first section, Dr. C. Haripriya, MD DGO, FSCOG London, Medical Director of Prashant Fertility Research Center, Fellow of Royal College of Obstetrician Gynecologist in September 2007, Fellow Lifetime Achievement Award 2010 by Gold Committee 2010 in collaboration with the Harvard University, USA, Best Doctor by MGR Medical University, Blue Ring Award presented to work on fertility and diabetes, Best Performing Doctor awarded by the Government of Tamil Nadu by meritorious service in the field of medicine. Now, I would like to introduce the second moderator, Dr. K.S. Jairani Kamraj, MD DO Diploma in Reproductive Medicine, Germany, FSCOG, Chief in Akash Fertility Center and Hospitals, Vadapalani, Consultant in Infertility and High Risk Pregnancy, was Advisory Committee member. She is the recipient of the following medals and awards: Rajamani Janakiraman Prize in OBGYN, Dr. Vadamalayan Endowment Prize, Gold Medalist, MBBS University First, Dr. Anantachari Prize for University First in Medicine, awarded the Women of the Year 2010 by the Lions Club, Achievement of Government Service Award by Exnora 2010, Mega EV Women Achiever Award in 2011, Nalam Hospital Women Achiever Award in 2011, Best Doctor Award 2012, Tamil Nadu MGR Medical University. I would like to introduce the third moderator, Dr. Papa MBBS, DGO, MD FICOG. She has completed ICOG Fellowship in Reproductive Medicine, Professional Diploma in Clinical Research, and Diploma in HIV and AIDS, Israel. She is currently the Senior Professor of Obstetrics and Gynecology and Art Coordinator in the Department of OBGYN, Women and Children Hospital, Jigma, Puducherry. She was former HOD in the Department of OBGYN and Head of Women and Children Hospital, Jigma. Present OGSP Founder Secretary of IFS, Puducherry Chapter, and President of Jigma Scientific Society from 2019 to 2020. For the following awards: Dr. C.S. Dawn Award, Best Paper Award, Indian Journal of Obstetrics and Gynecology, Best Paper Award, JSS 2, and K.D. Nair Award. She has presented 126 articles in national and international journals. I welcome all the 3 moderators to take your seats and continue the session. Thank you.
Dr. Somirup, you can log in, share with screen.
Yes, I share the screen.
And 1 second, Somirup, just wait, they will introduce, then you can share.
Yes.
Dr. Geeta will introduce Dr. Somirup.
Good morning. Welcome everybody to this wonderful session organized by Dr. Sanjeev Reddy. I think it will be a real hit like all the others have been. Thank you very much, Dr. Sanjeev Reddy, for this opportunity. Now the first session is by Dr. Somirup Dash. Dr. Dash is the Scientific Director of Swiss Hospital in Puducherry. He finished his undergraduation and post-graduation from JIPMER, Pondicherry, started the first ART center in the Union Territory of Pondicherry 10 years ago, which is now a full-fledged facility performing 1,000 cycles a year, and a cryobiology unit performing about 1,500 remote embryo transfers a year. He is a faculty in many national forums and has 20 publications in national and international journals, and he is a member of the ASRM and Indian Society of Assisted Reproduction. He will now speak on fluid in the endometrial cavity. Over to you, Dr. Soumya. We all know that it's fluid in the endometrial cavity is a very distressing situation. The day before the embryo transfer, many a time we find fluid which was never there. We all know that it hits the results greatly, and it's a very, very important topic to discuss. Over to you, Dr. Soumya.
Good morning. Good morning to all the esteemed faculty. Am I audible?
Yes, yes.
Good morning to all the esteemed faculty. I really feel privileged that after a long time I am there in company of such esteemed people, and I thank Dr. Sanjeev Reddy for this initiation. My topic today is fluid in the endometrial cavity, and I'll start my slides.
Recording on, no?
No.
Greetings from. Are the slides visible?
No. Soumya,
Yes, sir.
there is a green button is there, no, below. Just click on that. No, first open your presentation
Yes, sir.
on the desktop, then click on the share screen.
This is not coming actually.
You open your presentation and then you press your share screen. Soumya.
Can you see the share screen, other things?
Green one.
Yes, sir.
Press on that.
Now, which link you opened?
What I'm seeing, share screen.
It is there or not?
Down, not the bar.
No, whether you opened other thing there.
It's from the iPad. That is why. You open in your presentation first and then go to the Zoom.
I sent again one more link. You just see that is the faculty link. You might open the audience link.
Yes.
I sent
think
you
that is.
again. You just.
If he has opened the audience link, we wouldn't have seen him. So he's on the correct link only.
Okay.
Because we are seeing him and he's in the system. So he's on the correct link.
Okay.
Session, why don't you put his presentation if you have?
Yeah, madam, I have just spoken to him. Good morning, madam. Subbu here.
Yeah, morning. Subbu.
Yeah, I have just spoken to Session. He's trying to work.
Okay.
Doctor, can you find the, first of all, can you open the PPT, sir, on the iPad?
PPT, yeah.
So it's already open?
It's already open.
Okay, so I want you to come to Zoom, press the share screen button, and then share the screen, which is the first option that comes. Once you press share screen button, there will be multiple windows that open. On the top, you will see share screen. You will see one window saying screen.
Yeah.
Press on that.
Have you done that, sir?
Yeah. So
On the screen, there will be a small window with your presentation will be there. First click on that. then there.
After this thing, what it is showing is it is not going to my the option. It is not showing that.
Shanta, you are ready?
Stand up. Sorry, sir.
Sir, are you seeing the presentation?
All the way from India. India.
We can't see a presentation, sir.
Dr. Shanta.
Do you know what is the
Shanta?
population of India?
Yes, sir.
Will you
Yeah.
start? Huh?
Okay.
1
Right.
second, I will ask them to introduce you. Then we can
Of these billion people,
Request everybody to mute their mics, please.
the highest rate of illiteracy in the world. Rowan, you should be thankful that we have.
Dr. Jayrani, Dr. introduce Dr. Shanta Kumari.
Yes, sir. Yes, sir.
See, all of you, please keep your mics in mute position, please.
It gives me great pleasure and honor, and it's a pride to introduce Dr. Shantakumari Madam, who is the President-elect of FOXI 2120. She awarded a fellowship at Indian College of FICOG, and she is presently a consultant in Hyderabad, obstetrician and gynecologist and laparoscopist in Hyderabad. She has completed her MD, Depend B, FICOG and FRCP, and she is a professor of OBGYN Deccan Medical Colleges. And her professional membership is Secretary of Indian College of Obstetrician and Gynecologists between 2015 and 2018. And she is a member of FICOG Working Group on Violence Against Women between 2015 and 2018. And she is Vice President of Federation of Obstetric and Gynecological Society of
Patient,
India.
can you see somebody is disturbing us?
And she's a IAG Managing Committee member between 2015 and 2016. She's a chairperson of IMS Education Committee between 2015 and 2016. She's national corresponding editor of the Journal of OBGYN of India between 2011 and 2013. And she's the secretary of TCOGS 2015 and 2018. And she is the chairperson of MNNRRC FOXI between 2008 and 2010. And Madam will be now talking about single fetal demise in twin management. We as an ART specialist, we are always happy to have a twin, but when something goes wrong with a twin pregnancy, one getting demised at any trimester, it is a real stress for the consultant and also for the patient. So managing such a situation is really a challenge, and it needs a lot of insight, a lot of knowledge, a lot of counseling, passion, everything together. To enlighten us in this context, Madam will be talking on this beautiful topic of single fetal demise in twin management. Over to you, Madam.
Yeah, I'm trying now. Yeah. Good morning, everyone. Good morning, friends. It's indeed a pleasure to be here on a Sunday morning. And at the outset, let me tell you, how is it possible that on a Sunday you got us on a webinar? This is because of this one gentleman called Dr. Sanjeev Reddy. People who would have met him once or twice would have thought, such a soft-spoken person who actually doesn't talk much, is such a silent man. But friends, let me tell you, the more you know him, you will know what an interesting personality Dr. Sanjeev Reddy is. He has got a capability of making and convincing anyone who doesn't want to be on the webinar also to come on to the webinar. You're seeing it because we have got some very good speakers on this webinar whom only Sanjeev Reddy sir could convince to be on the webinar. And I have been seeing that the TAPI sir has been doing fantastic programs. And as usual, he has managed to get all of us from this part of the country to be on the webinar today. So thank you, sir. I'm sure it's going to be a wonderful webinar. And honestly speaking, I was really awed by the CVs of the chairpersons. All three of them were fantastic. Huh? So it is actually making me a little conscious when I'm going to talk in the August presence. Well, friends, today we are going to talk about the management of twin pregnancies with single fetal demise. I'm a consultant at Yashoda Hospitals, no longer in professor in the medical college, which was mentioned by Jairani. And a pleasure to be with you all. So, friends, what is it that nowadays is of interest to us? You will agree with me that any topic which starts or any discussion which happens between gynecologists in these days are actually hovering only around one problem, and that is the COVID and the corona. But friends, let me tell you, in spite of the pandemic, we have to understand that the obstetricians or the obstetrics is the only specialty which has got all the issues which are there, which are actually the same even in the pandemic. So we need to understand that in spite of trying to tackle the pandemic, we need to be very clear about the management of the simple problems or which can actually become a very big enigmatic problem in obstetrics. And looking at the multiple pregnancies, I'm sure you agree with me, there's definitely a rising incidence of multiple pregnancies and 4 times increase in triplets since 1980s to 2003, thanks to the ART and all the specialists we have got on the webinar today, who are actually doing a great job of trying to make women who couldn't conceive on by themselves mothers. So congratulations to all of you for trying to give that happiness to the women of our country. Friends, when you look at the ovulation induction, 5% with clomiphene and 60 to 40% with HMG, the number of clinical situations actually dealing with multiple pregnancies, complications has also increased simultaneously. And single fetal demise. Now, any obstetrician who is actually dealing with a multiple pregnancy, and especially when that multiple pregnancy is a sequelae of an ART, where as it is, the woman is stressed out and they're so concerned and worried about the outcome that adds to the stress of the obstetrician. So this single fetal demise can be a significant clinical event depending on the chorionicity of the pregnancy and the gestation at which it takes place. And we need to know that it affects about 6% of the twin pregnancies. The early pregnancy phenomenon of spontaneous loss of one fetus, known as the vanishing twin sequence, is well known, as it does not actually cause adverse effects on the perinatal outcome of the surviving twins. But once more, again, we need to understand the most important prognostic feature in the single fetal demise still remains the chorionicity. You all agree that you know about this dichorionic lambda sign, the monochorionic T sign. You have to understand one point, that chorionicity of the pregnancy is very important, very vital, which has to be established by 11 to 14 weeks. So friends, you may be the best of ART specialists, you may be the best of obstetricians, but remember, if needed, you actually need to take the help of a fetal medicine specialist who can give you an accurate idea about the chorionicity at the right time. So no harm in taking the help of a fetal medicine specialist who will be actually able to give you the idea of what exactly is the chorionicity, and that will actually help you in the management of the patient. Now, twin pregnancies are definitely at a high risk gestation with elevated perinatal mortality rates. Single intrauterine fetal demise actually occurs in about 3.7 to 6.8% of all the twin pregnancies. And death may occur anytime and increases the mortality and morbidity of the survival twin, secondary to the cause of death of the co-twin and to preterm labor or both. Now you have to note one thing. In the present scenario, what is one of the most important issues we obstetricians are facing? Friends, there is a rise in preterm labor. This, we are really not sure whether it is because of the COVID-19, but definitely there are, maybe as the time is evolving, we are getting more evidence, and then we will be able to come to a conclusion that this COVID could be the reason for the preterm labor. So we have to be very careful, especially when you are having the multiple pregnancies and you have to deal with the preterm labors. And single intrauterine fetal device in a twin pregnancy is already complicated case. And it has a different consequence in terms of the fetal effects and the feto-maternal problems compared to a singleton pregnancy. Now, the etiology of the single intrauterine fetal demise in a twin pregnancy could be either similar to that of singletons or it could be unique to the twinning process. The common cause of the single fetal demise, genetic and anatomic anomalies, abruption placental insufficiency, absolute or discordant growth restriction, cord abnormalities, infections, maternal the disease, including the diabetes and sometimes hypertension. Very important. We find that there is an increased incidence of hypertension. There are unique complications of the monochorionic twins like the twin-to-twin transfusion syndrome and the twin anemia polycythemia sequence. Chorionicity and the single twin demise. The prevalence of the single intrauterine fetal demise among dichorionic twins is lower than that reported for the monochorionic twins. The prevalence of monochorionic twinning actually in the case of single intrauterine fetal demise in twins is about 50 to 70%. That is the reason why we need to know about the chorionicity. And ART has also increased 5-fold the frequency of monozygotic twinning. Chorionicity and single fetal twin demise. The monozygotic gestation might be dichorionic or monochorionic, but the monochorionic subset of monozygotic twins notoriously carries an exceptionally increased risk of pregnancy loss, congenital anomalies, twin-to-twin transfusion syndrome, the selective intrauterine growth restriction, and the intrauterine death. See, the mechanism of twinning is very simple. You ask any postgraduate, they will know that monozygosity, you got dichorionic diamniotic, 0 to 4 days division, and little later 4 to 8 days you got the monochorionic diamniotic twinning, and 8 to 12 days you got the monochorionic monoamniotic, and later you will get conjoined twins. So we need to understand this for us to get an idea about the management of the twins. Chorionicity rather than zygosity is very important determinant of the risk of intrauterine mortality and morbidity. The sequelae of this IUFD in a twin pregnancy mainly depends on the chorionicity and the gestational age at diagnosis. Now just look at this picture, the fetal demise in twins, the placenta and fetus. One fetus, one placenta. This monochorionic twins, there are 2 fetuses but 1 placenta. The dichorionic, you got 1 fetus, 1 placenta. So the maternal reasons for single intrauterine fetal demise, hypertensive disorders, thrombophilia, abortions, assessment of the risk is based on maternal parameters and decisions for management may have an effect by purely maternal indications even with grave risk to the surviving co-twin like extreme prematurity. The fetal reasons for the single intrauterine fetal demise: infection, chromosomal anomaly, structure anomaly, cord anomaly, entanglement, and velamentous. The placental reasons for a single intrauterine fetal demise: placental twin-to-twin transfusion, twin anemic polycythemia sequence, and selective intrauterine growth restriction. The placental causes are more common in monochorionic twin single fetal demise. The special reasons for single intrauterine device: iatrogenic selective feticide, complication after laser therapy for twin-to-twin transfusion syndrome, pathophysiology and complications of the death of a twin. The exact mechanism leading to the risk of morbidity and mortality of the co-twin after single intrauterine fetal device are yet to be proven. There are 2 main theories: ischemic theory, thromboplastin theory. The former theory is being the most supported, and these 2 theories are specific to monochorionicity. Single fetal demise, the effect of chorionicity. Now look at this picture. They got this dichorionic and then monochorionic diamniotic 2 sacs, monochorionic. So here, and then you look at this. And when this monochorionic twin is affected, you can understand the vascular connectivity between the death twin and the live twin. And this is the cause of anxiety and concern. What is the complication of fetal death of a twin? The death of a co-twin, the risk of co-twin death following the death of a twin after 20 weeks, 12% for monochorionic twins and 4% for dichorionic twins. The neurological sequelae, the dichorionic twins are actually hemodynamically independent. Death of a monochorionic twin may damage the co-twin by thromboplastin theory and ischemic theory. The cord entanglement, which is unique to this, the monoamniotic twins are at an increased risk of cord entanglement and subsequent intrauterine fetal demise. Similar to the situation in the singletons, the etiology of intrauterine fetal demise is often remaining elusive. Complication of fetal death of a twin, preterm delivery. The risk of delivery before 34 weeks is higher for the monochorionic than for the dichorionic. Always remember this, 68% versus the 57%. Labor is often occurring spontaneously 2 to 3 weeks after the recognition of the fetal death. Can occur almost immediately. Placental abruption may be delayed for some months. Complication of fetal death of a twin, injury to the other systems, renal cortical necrosis, unilateral damage of a kidney, the small bowel atresia, gastroschisis, aplasia cutis, and terminal limb infarction. But these are less common than the CNS injury. We are actually very concerned about the CNS injury. Now let's look at this BJOG, an International Journal of Obstetrics and Gynecology, where prognosis of the co-twin following the spontaneous single intrauterine fetal death in twin pregnancies. A systematic review of meta-analysis. This has shown when you have a co-twin demise, preterm birth, abnormal antenatal brain MRI, all the adverse outcomes are more common in the monochorionic than in the dichorionic. Now, how are you going to manage the single fetal demise? The nature of the placentation, the chorionicity determines the precise management. Consideration should be given to the use of corticosteroids to promote the fetal lung maturity, MAC sulfate for neuroprotection. The neonatal pediatric consultation should be arranged and close discussion between the parents, obstetrician, pediatrician over subsequent weeks is very essential. And when you just look at this algorithm, a multiple pregnancy with single fetal demise, you have to be very supportive. You have to give them information. You have to give them nutritional advice and then determine the chorionicity. And most important, then starts your monitoring for the specific complications. The discordant fetal growth, fetal anomaly, single fetal demise, twin to twin transmission. This is the NICE guideline. Now, expected maternal problems after single fetal demise. The development of a coagulopathy, if the dead fetus is retained for more than 4 weeks, is remarkably uncommon if the co-twin is alive. Nevertheless, consideration should be given to perform weekly fibrinogen levels with a platelet count and a partial thromboplastin time after 4 weeks of confirmed fetal death. A full coagulation screen should be performed based on before regional analgesia or delivery. Single intrauterine fetal demise. Coagulopathy is uncommon. Maternal surveillance with weekly hemogram with platelets, antiplatelet APTT after 4 weeks. Fetal surveillance with weekly Dopplers and 2 weekly gross assessment serially. How are you going to manage the single fetal demise? Dichorionic diamniotic. Delivery should be delayed until at least 34 weeks of gestation, provided that there is no obvious continuing pathology that may cause demise in the surviving co-twin. Carefully monitoring with the serial ultrasound assessment of the growth, Doppler blood flow studies as well as regular cardiotocography should be undertaken. Management of single fetal device, monochorionic diamniotic. When fetal death has been identified in one of the monochorionic twin pair, the neurological injury has already been inflicted. If the fetus has survived that insult, delivery should be delayed as long as possible. Weekly ultrasound should be performed looking for evidence of changes. Now, an MRI 3 weeks after the fetal death is diagnosed if recommended. If intracranial pathology is detected, neonatal pediatric consultation to be arranged. Some reassurance can be offered to parents if the fetal MRI and serial ultrasound remains normal for many weeks after the fetal death, but a guarded prognosis is strongly advised. Now, monochorionic diamniotic twins. Doppler assessment of the fetal middle cerebral arteries may indicate anemia in the surviving co-twin. The presence of fetal anemia in the surviving co-twin is not surprisingly associated with a significant poorer prognosis. the use of a rescue fetal blood transfusion could be considered if fetal demise is of very recent origin and fetal anemia is evident in the co-twin. It's unlikely to be of any great value given the timing of causation of these neurological injuries. Now, monochorionic monoamniotic. The majority of death in the monochorionic monoamniotic twins involve the death of both the twins. Occasionally, a single monochorionic monoamniotic twin may survive the death of its co-twin. If the death has occurred at a very preterm gestation to delay delivery to allow administration of steroids and MAT cells in this monochorionic monoamniotic, delivery by 28 weeks would be a reasonable answer in these circumstances, although it may be too early to detect intracranial pathology. Single intrauterine fetal demise, complications, death of a co-twin, neurological sequelae, and risk of preterm. See, odd of death is 6 times higher in monochorionic after 20 weeks compared to dichorionic. We've got the thromboplastin theory, passage of thrombotic material from a dead fetus to the surviving twin. Ischemic theory, sudden hypotension causing flow from the surviving twin. I've shown you that picture, remember, where if one twin dies, suddenly the blood from this alive twin will go into that dead twin. So this will cause sudden ischemia, hypotension in the surviving twin. And we really don't know how much of neurological damage happens in the surviving twin. And this is the cause of concern. Cerebral palsy, porencephaly, multicystic encephalopathy. The single intrauterine fetal death demise, the death of one twin, antenatal steroid cover, magnesium sulfate for neuroprotection. Labor usually starts more than 90% within 3 weeks. Now you have a dichorionic diamniotic, then delay till minimum 34 weeks, maximum 37 weeks, weekly biophysical profile, NST, serial growth monitoring. Monochorionic diamniotic, weekly serial ultrasound, MRI after 3 weeks. Then no damage. If neural damage present, consider fetal. Let me go back 1 minute. And this monochorionic monoamniotic, 28 weeks, admit intensive monitoring, more than 28 weeks, wait, don't wait anymore, immediately do the delivery. Now, planning delivery with a co-twin demise. If the live twin is leading, well grown and is in a cephalic presentation, then vaginal delivery may be considered. If the live twin is malpresented or a growth restricted, or if the dead twin is leading, cesarean section is preferred. Many parents prefer cesarean section, and I'm sure all of you will agree. It's very easy to talk about the management, give a vaginal delivery when we are talking and giving a lecture. But actually, when you have a case where you have got a single fetal demise in a twin, as an obstetrician, we are so scared, worried. We would never actually have the guts to go and give a vaginal delivery. So probably the incidence of cesarean section is more, but then we are not wrong because we are very concerned about the live baby. And per se, definitely not an indication for cesarean, they say, but all the things which we have discussed, but then we have to individualize the patients and our management should be based on that. So practice point, the exact rate of the single intrauterine fetal demise is very difficult to determine, but can occur in about 6.2% of twin pregnancies. Monochorionic survivor twins are at 5 times higher risk of death, 15% after single intrauterine fetal demise compared to a dichorionic twin. Monochorionic twins are at least 4 times higher risk of neurological sequelae, 26% following the single intrauterine fetal demise compared with the dichorionic twins. After the single intrauterine FD, preterm delivery rates of the surviving co-twin do not increase. The clinical goal is to optimize the outcome for survivor while avoiding prematurity and its potential adverse sequelae. An ultrasound, middle cerebral artery Doppler, and MRI are useful to evaluate the potential injury in the surviving co-twin. And preemptive preterm delivery after single intrauterine fetal demise is inappropriate and adds to the complication of prematurity. Psychological support for the parents and the obstetricians, both are important. So always discuss with your colleague so that you can have more courage in handling. Detailed counseling should be offered to discuss the options and management. Now, after single fetal demise, the cause of single death, if it's continuing, then you deliver. If it is resolved, probably steroids and magnesium sulfate. In dichorionic diamniotic twins, you deliver more than 34 weeks. Monochorionic twins, more than 28 weeks. You deliver less than 28 weeks. You do intensive monitoring and then deliver at 28 weeks. With monochorionic diamniotic twins, weekly ultrasound, MRI very vital after 3 weeks. And if you find intracranial pathology, probably consider feticide. But in our Indian scenario setup, it's actually in fact a very difficult decision to do this feticide. And if there's no intracranial pathology, probably you can continue monitoring the patient and deliver at term. So finally, friends, the management of single fetal device in a twin pregnancy can be very difficult for any obstetrician. Identify the cause, monitoring of the co-twin, a team approach, very important, involve a fetal medicine specialist, involve the pediatrician, a neuropediatrician, counseling with a psychiatrist, a psychological counseling is very important potential for, and sometimes a very difficult circumstance. It can be challenging. Knowledge of the chorionicity is very, very vital. So please don't hesitate to determine the chorionicity when you have a multiple pregnancy right in the beginning. Don't wait for long before you send. So friends, that is how we actually have to manage the case of single fetal demise. Most important is please take care of yourselves in these days, because you are very important for the women of our country. So we want each one of you to be safe, healthy, because once all of you are safe and healthy, then only you can take care of the women of our country. Thank you very much for the time.
Thank you, madam. Thank you for the very elaborate, crisp, and very very apt way of presenting a single demise in a twin pregnancy. And we really appreciate that we have to note the chorionicity. That is very important when we decide very early. So that gives us more time for counseling, taking all precautions and preparing the mind of the women of all these complications. That will help us in the obstetric management. And we thank you for the nice take-home messages that you have given. And we thank you that as a president, we take up your words to stay safe, to be safe always. Sir, are we having the questions now or at the end, sir? Sanjeeva, sir?
At the end of the session, madam.
Fine, sir. Fine.
Thank you, Dr. Shanta, in spite of your engagement, sparing your valuable time and delivering the excellent lecture. Thank you.
You will not have a no for an answer, I can assure everyone.
Absent of current with so much of humidity, madam is taking up. That's nice.
Dr. Soumrup, you can share now. Das.
Yeah. Can we start?
Yes. Put in the slide mode. Slideshow mode, please. Oh, okay. Start.
Yes. I'm sorry for the initial glitches. Next slide. Yeah. I'm sorry for the initial glitches, but this is my first webinar where I'm a speaker. So that is why the things were a little. And now also I have sent my presentation to the coordinator, and he will be changing the slides. So there might be some confusion. I again apologize to you.
No problem.
For this,
We can proceed
for
with
this
the
problem. Yeah. So my topic, as Geeta Haripriya madam had initially told, my topic is a very difficult situation to deal in the settings of ART. That is fluid in the endometrial cavity, or in other words, it is also called as serometra. Can I have the next slide? Next slide, please. So the incidence, the slide before this, I think. Slide
so
before this.
Previous slide,
yeah. So the incidence of this condition is around like 3 to 8%. Though I have in my personal practice, I have seen it a little lesser than that, not so frequently. And the most important thing in this is, when does this fluid occur? when does this fluid occur? Is it before the stimulation or after the stimulation? That is something which is key to understanding and giving a positive result in our ART cycles. Next slide, please. Next slide, please. Yeah, the causes of fluid in the endometrial cavity. One of the most important cause, I think, would be hydrosalpinx. The first is hydrosalpinx. Very commonly, I have also seen large endometriomas. This also is one of the important causes of fluid-like appearance in the endometrial cavity, and the rest of it has been elaborated in the slides here. One of the important causes is again polycystic ovarian disease. During the stimulation process, one might see mild amount of fluid in the endometrial cavity. Next slide, please. So the pathophysiology of this condition is really unknown. Why it happens, how it happens. Sometimes the theory says, how we have a theory of the backflow theory in endometriosis, where there is flow of menstrual blood into the tubes. Similarly, there can be a flow in the opposite direction which can show fluid in the endometrial cavity. But overall, the pathophysiology is not known. So what happens when there is fluid in the endometrial cavity? The problem is about embryotoxicity. There is a disruption of the embryo endometrial interface, and there can be a mechanical loss of embryos, sometimes leading on to impaired implantation or an ectopic pregnancy. And all this is a result of a cascade of cytokine glycoprotein interaction, which reduces overall endometrial receptivity. Next slide, please. Yeah, this is something which I had already spoken before this. The importance of this is, when does this fluid occur? That is key to understanding what to do and how to proceed with the problem of serometra. If it is there before stimulation, then the prognosis is generally bad. If the fluid occurs during the stimulation period, somewhere around the 7th or the 8th or the 9th day, then usually the prognosis is very good. Next slide, please. So, how do we diagnose it? We diagnose it by transvaginal ultrasound. Next slide. The importance. So, by transvaginal ultrasound, we diagnose this condition. And what is important in this? What should be noted in the ultrasound? The ultrasound, what one should note is the anteroposterior diameter. Anteroposterior. Can I have the previous slide, please? Yeah. The anteroposterior diameter of the fluid collection, if it is more than 3.5 millimeters, then it is no point in transferring embryos. It is not going to. This is a very important study which came out way back in 2010. It is better in such scenarios to freeze the embryos rather than transfer it. Even trying to aspirate the fluid, it doesn't help if you see that it is more than 3.5 millimeters. So what is the treatment of this? And it should be individualized. It is depending on the cause, the time, again and again, as I'm mentioning, the time of appearance and the amount of fluid accumulated. What I told you previously, if it is less than 3.5 millimeters in the anteroposterior diameter on the ultrasound, then the prognosis definitely is much better. Next slide, please. So in the principles of treatment, one of this to eliminate the cause, to promote drainage of the fluid and prevent fluid over generation, and prevent the fluid entering the endometrial cavity. All this complex interplay helps in giving a better chance of implantation. So in the treatment options, we have an expectant management, postponing the embryo transfer, sometimes transvaginal aspiration, salpingectomy, and something called the Assure application. I will be detailing these in the next slides. So expectant management. This is a very important thing, an important mode of management actually. During stimulation, during controlled ovarian, sometimes what usually happens is that there can be fluid accumulation in the endometrial cavity, but especially in patients who are PCOS, in polycystic ovarian syndrome, this is usually seen. Most of it disappears after starting progesterone. If you are planning on a fresh transfer in PCOS, if you are planning, which actually should not be done, but if you are planning a fresh transfer in these kind of patients, after giving progesterone, usually it disappears. So expectant management is a very important line. If you see, and this works usually when the fluid is present during the stimulation. After the stimulation starts, if the fluid is present, then expectant management also is likely to work out. Next slide, please. Next slide. Yeah. The second option is postponing embryo transfer. Now, where would one want to do this? Where would one want to postpone embryo transfer? This is done in a scenario, particularly with if the anterior posterior diameter of the fluid collection is more than 3.5 millimeters, or if the fluid is present even in very early stage of stimulation, means indicating that it is probably a hydrosalpinx. In such cases, postponing embryo transfer is a wise option. And to deal with the cause of hydrosalpinx, deal with the cause of fluid in the endometrial cavity after it has been dealt, then a remote embryo transfer can be done sometime later on. Next slide, please. So the other option, freeze all, is postponement a bad sign? If we have postponed the embryo transfer, usually if we don't deal with the primary problem, then it's again going to recur in the next subsequent cycles also. The entire idea of freezing is to deal with the primary problem and then proceed ahead with the ET, embryo transfer. Next slide, please. The third option is aspiration and proceed. Is it the right option? Next slide. So what can be done? Suppose this option can be exercised only if the fluid collection is seen somewhere around the 8th or the 9th day of stimulation. In such cases, sometimes if transvaginally, you can put a thin catheter, embryo transfer catheter, and just aspirate the fluid and start progesterone. That is one of the options which can be done at the time of ovum pickup. This thing can be done. And if you are planning a blast transfer, 5 days of progesterone, it will probably lead to the minor damages in the endometrial cavity, which could have resulted from this transvaginal aspiration. Next slide, please. So the next option is tackling the cause, surgical options. Surgical options would include to tackle the hydrosalpinx. Tackling the hydrosalpinx is one of the surgical options which is available. The other non-invasive, lesser invasive surgical options is just occluding the tube. Sometimes the hydrosalpinx might be so big and so encased in bowel adhesions and all, it might be difficult for us to remove the tube. In such a case, the compromise would be to just occlude the tube. I will show you in the next slides that this is generally not recommended, but if there is no possibility of taking out the tube, then at least that would be done. The gold standard is to remove the entire tube. The gold standard is to remove the damaged tube. Occlusion, it still has to stand the RCTs telling that occlusion gives a greater pregnancy rate that has not stood the test of time and not stood the randomized control trials also. Tubal aspiration also using ovum aspiration needle has not shown to be increasing pregnancy rates. Next slide, please. Yeah. So as I had mentioned previously, the option of laparoscopic salpingectomy should be considered for all women with hydrosalpinges who are to undergo IVF. Let me just elaborate a little bit on this. We have had so many interventions which were thought to be beneficial for increasing pregnancy rates in ART. One of the examples are like endometrial coring, endometrial scratching. These are all surgical polypectomy, hysteroscopic polypectomy. These are all interventional procedures which were thought to increase the pregnancy rates. But the only surgical intervention which has stood the test of time and randomized control trials is the removal of a damaged tube. So only this surgical intervention has actually shown to improve pregnancy rates. Next slide, please. Assured application, this is an alternative. It is currently off-label. I also don't have any experience regarding this. Next slide, please. Assured application is just hysteroscopically occluding the tubal ostia, to prevent the toxic fluid, hydrosalpingectic fluid, from entering the endometrial cavity, where we cannot, do because there are pelvic adhesions, you cannot remove the tube. In such cases, this is an option, but it is not available in India yet. These are some lesser known options. Sclerotherapy, what could be done if, again, you cannot approach the tubes and there is a risk of bowel damage where the tube is encased in adhesions. One of the ways to one of the proposed modality of treatment is sclerotherapy, wherein, as you know, you can aspirate, then followed by alcohol washing and injection of tetracycline. But these are lesser known treatments. Efficacy is not very well known. Next slide, please. Next. Next slide, please. Yes. So finally, coming to what actually is all fluid bad in the endometrial cavity? No. Finally, one has to understand this uterine secretonomics, that finally it is this fluid which actually is important in endometrial implantation. An excess of it sometimes can displace embryo. So one should always not dismiss the fact that any amount of fluid in the endometrial cavity is bad. That is not the case. Next slide, please. So finally, fluid in the endometrial cavity is a complex scenario to deal with. A multi-pronged approach can sometimes solve the problems, but in worst case scenarios, even then also with this multi-pronged approach, if one is not able to deal with the problem, then the last option of surrogacy can be considered. Next slide, please. This is just a detailed chart. What I have spoken, it has been just put in a flow diagram form. I have come to the end of my talk, and I would be really happy to take questions in this. Sanjeev Reddy sir, Madam Geeta, Madam.
Heather,
Thank you very much, Soumyaru. Dr. Sanjeev Reddy, are we taking the questions now or at the end of this?
After the next talk.
Okay.
Kedar, just stop your presentation. I will put your slide for introduction. After that, you can share. Kedar, will you able to? Kedar? Sana? Sana,
Yes, sir.
just see that Kedar, ask him to unmute his mic.
Sure, sure.
Kedar,
Yes, sir.
just stop your.
Yes, I have
just,
stopped.
No, it is there.
Okay.
Stop sharing.
How to do this?
Okay, Kedar, your screen is visible, so you can start to talk.
Dr. Reddy, Sanjeeva Reddy wants you to show his slide.
Sana,
but how do I get this?
No, upper part, no, there is a red button will be there.
Yeah.
Click that one.
Okay. Okay. Sorry.
Okay.
Very sorry.
No problem. Okay, Dr. Papa, you can introduce.
Morning to all of you and welcome again, and I thank Dr. Sanjeev Reddy sir to have given me this opportunity to participate in this webinar. Dr. Kedar, welcome. To introduce Dr. Kedar Gandla, he has done his MD, DNB, FCPS, DGO and DFP. He is a consultant and fertility physician, honorary secretary general of ISTAR, awarded many national and international awards and scholarships of those Canadian International Development Agency, Federation of Fertility Societies. He is visiting international fellow program at Royal Victoria Hospital at Montreal. He has over 25 national and international publications and has delivered more than 500 lectures and talks and conducted over 100 IUI workshops. So welcome Dr. Kedar. We are expecting you to deliberate on this topic of recurrent pregnancy loss, which is very, very controversial, but it has no definition, no consensus on the investigations, and also in the management. So lots of controversies. And I hope you give us the latest information regarding the definition of unexplained recurrent pregnancy loss, what investigation to be done, and what is the management, whether we go by evidence-based or practice-based, experience-based. Welcome.
Thank you. Thank you very much. At the onset, I would like to thank Dr. Sanjeeva Reddy and Tapisar Society for inviting me here for this prestigious talk. This is a subject which attracts a lot of attention. If you look at the incidence of causes of recurrent pregnancy loss, about 50% of the causes you will come to know after doing batteries of investigations, expensive batteries of investigations, you will tell the patient that it is unexplained. Or you say idiopathic, means the idiot doctor and the pathetic situation of patient saying that at the end of the whole thing, I don't know the cause. I really do not know the cause of your abortion. It could be because of all these causes leading to deficient interaction at a correct timing could lead to reproductive failure. So the talk is all about thinking out of the box. Is it the soil or the seed? Is it the egg, the sperm, the embryo, or the endometrium? All three interacting together, leading to a miscarriage. The most important is, can a male be a cause of recurrent pregnancy loss? At the present moment, the society doesn't even think the male is responsible for infertility, because they go to the gynecologist first and they don't go to the endocrinologist, as still 50% of male are responsible for infertility. Look at this study published in 2003, where they did DNA fragmentation on 24 partners of patients with unexplained recurrent pregnancy loss and compared DNA fragmentation with donor of known fertility and unscreened population the DNA fragmentation was found statistically high as compared to donor and general population. So what it means that sperm DNA fragmentation or damaged sperm can play a role in unexplained recurrent pregnancy loss despite of normal semen parameters. It's like unexplained infertility. Again, looking at the relationship between the DNA fragmentation, free radical index and antioxidant capacity in the seminal plasma. So 42 men with DNA fragmentation looked into DNA fragmentation, sperm motility. So what they found, sperm motility was less in recurrent pregnancy loss, DNA fragmentation was high, antioxidant capacity was low. So basically DNA fragmentation can be considered as one of the contributory factors for a spontaneous abortion. Then they looked at the sperm fish analysis and they found that there was increased aneuploidy because the sperm DNA fragmentation would lead to aneuploidy of the sperm, which was again picked up by sperm fish analysis. So basic mechanism, some amount of ROS and antioxidants level required for normal sperm capacitation acrosome reaction. But if the ROS is more than antioxidant, will lead to antioxidant or oxidative stress, leading to lipid peroxidation, DNA damage, leading to decreased sperm motility and quality reduction into the sperm pregnancy. So increase ROS, decrease antioxidant capacity, damage the plasma membrane affecting the sperm motility, and DNA fragmentation leading to decreased fertilization and early embryo death. So when do you do what investigation? So what I suggest is do a semen analysis and blood sugars, which I know alarmingly high diabetics are seen now above the age of 35 in male population, and a sperm DNA fragmentation in a patient with unexplained recurrent pregnancy loss. This is a systemic meta-analysis published in 2018, where 12 prospective study and 2 retrospective studies, 530 versus 639 fertile control. They did sperm DNA fragmentation by different techniques, and they found the couple with history of idiopathic RPL had high sperm DNA fragmentation. So what they're suggesting is potential paternal derived origin of unexplained recurrent pregnancy loss. We know antioxidants are very good, helps in improvisation of sperm parameters, improves natural pregnancy rate, improves IVF conception rate, and decrease miscarriages. Strong recommendations are L-carnitine, coenzyme Q10, and lycopene. Nutritional supplement like zinc, vitamin B6, B12, folic acid. What we should do is combination, because there are no head-to-head studies. So there is no study of L-carnitine versus coenzyme Q10. We know individually they are good, but there is no head-to-head study. Hence, we have to do a mixed data. Now, antioxidants in male infertility, which talks about that it's a high quality study conclude antioxidant intake is associated with increased live birth rate. It's not pregnancy rate. See, live birth rate and representing increase by 2.1-fold increase, and subgroup analysis shows natural pregnancies and antioxidant supplementation increases pregnancy rate again to 12 to 26% with increase in 1.7 to 3.7-fold increase in pregnancy rate. So in the present armamentarium for male infertility, if you know the cause, you treat the cause. If it's a varicocele grade 3, he is a smoker, he is obese, he is diabetic, you treat it. But at the same time, antioxidant adding to that would help to improve the outcome. Our own paper from Dr. Neena Malhotra from Indian Journal of Medicine, prospective study from Maulana Azad Medical College, 30 male partners of RPL, they did yoga-based lifestyle intervention. And they gave only 21 days. So this is something which is unusual. For 21 days to produce impact is difficult. But what they found, that ROS level in the seminal plasma were less. And sperm motility and sperm count was increased, and they found increased DNA fragmentation, decrease in DNA fragmentation. The important aspect is this balancing out between sympathetic and parasympathetic nervous system by yoga-based lifestyle technique is something which I think we should be looking at. After the male factor, can it be a female factor? We know PCO is a contributory factor, but is diminished ovarian reserve can be a cause. And way back in 2001, they conducted the study. They conducted the study to look at diminished ovarian reserve in patients who have conceived with only 2.7% pregnancy rate, out of which 71% had a high miscarriage rates. Clomiphene challenge test was found to have a similar incidence as infertile population in patients with recurrent pregnancy loss. Day 3 FSH was raised in population of recurrent pregnancy loss. AMH and estradiol was significantly lower, 2016. Cochrane database again says very low quality of giving antioxidant might help in infertile patients. Again, a subgroup systemic meta-analysis, 2019, 15 studies. They found more women with recurrent pregnancy loss seems to have decreased ovarian reserve. So they will have low AMH and AFC. So women with unexplained recurrent pregnancy loss has decreased ovarian reserve with low AMH. So there is an apparent association between the two, and AMH, low AMH and low AFC can have a high risk of pregnancy loss, so more studies are required. So now presently, no professional societies like ASRM or RESHRI does not recommend to do this ovarian reserve testing. They did a prevalence study and they found higher percentage of patients, 48%, who had recurrent pregnancy loss had decreased ovarian reserve. So it's I think in our country, when you have an early pregnancy loss up to 6 to 7 weeks, before, it's not the APLA type of pregnancy loss where the heartbeat comes and disappears. Early pregnancy loss, I think these two investigations, even do a day 2 scan and look at the ovarian reserve, and if it's less, then documenting with AMH would help to guide and counsel the patient for treatment option. Then comes the soil, the endometrial thickness. Now, looking at the subendometrial blood flow, what they found that the Doppler, the power Doppler ultrasound done on the day of oocyte retrieval, those patients who became pregnant and had a live birth rate had good endometrial blood flow, and those who have deficient blood flow had 28% abortion rate. So basically, abnormality in the endometrial blood flow could be a cause for recurrent pregnancy loss in cases of unexplained recurrent pregnancy loss. Now, when we are saying unexplained recurrent pregnancy loss, means by doing standard tests, we have not been able to pick them up. And these tests are not included in the current armamentarium of investigation and evaluation. So that's why we are saying that maybe looking at this pulse Doppler ultrasound or power Doppler ultrasound. So this is a very dynamic paper, came back in 2015. See what they did, they looked at the decreased endometrial blood flow and receptivity in the luteal, mid-luteal phase. Now let's go back to the reproduction. Ovulation happens. Most of the studies have looked at the ultrasound of the endometrium on the day of ovulation or oocyte retrieval. But very few people have actually looked into mid-luteal phase when the implantation happens. And this is what the paper is all about. At the time of ovulation, estrogen is little high, progesterone is low, the vascularity is different. At mid-luteal phase, when the progesterone levels are high, estrogen is relatively low, the endometrial vascularity is going to be completely different. And they found that the mid-luteal phase had decreased vascularity indexes, which had a higher miscarriage rates. So we know that angiogenesis in female reproductive organ, especially the endometrium, plays a dominant role in playing the endometrium and implantation. Doing a power Doppler ultrasound, not a color Doppler, helps in improvising the low velocity flow and helps in visualization of smaller vessels. And we have drugs like sildenafil citrate, aspirin, which can help to improve the endometrial blood flow. Now, decrease endometrial blood flow, look at antiphospholipid antibody. Okay, so what they did, antiphospholipid antibody syndrome, 2012 paper, they did color Doppler ultrasound and they found that in recurrent pregnancy loss, because of antiphospholipid antibody, at mid-luteal phase, they had decreased vascularity index. Then they had a peripheral blood uterine natural killer cell. They were increased in patients with recurrent pregnancy loss. And as they increased, the recurrent pregnancy loss were a little more. But once you start low molecular weight heparin, they found that uterine artery blood flow decreased, the resistance decreased, and the pregnancy outcome was as effective as the control cycles. Another paper, like low molecular weight, we can give aspirin. Aspirin also decreases the mid-luteal phase, improving the uterine blood flow. So this is a typical endometrium. You find the color Doppler showing decreased blood flow to the endometrium. And here you see the blood flow is there in all the blood vessels, all the layers of the endometrium. Now, peripheral natural killer cells and low molecular weight heparin. 33 pregnant patients with previous to RPL, they found that the peripheral natural cells were calculated by flow cytometry. They did a color Doppler ultrasound to load uterine artery resistance. They found in recurrent pregnancy loss, uterine artery resistance was high, and giving low molecular weight heparin helped to increase the pregnancy outcome. So uterine artery resistance was decreased after 1 week of low molecular weight heparin. Now, I'm not advocating, but this has become a little trend that any recurrent pregnancy loss, if you do not understand giving low molecular weight heparin, maybe these are the type of pathologies, antiphospholipid antibodies, NK cells, which shows improvisation in the endometrial blood flow. So increased peripheral natural killer cells, okay, can lead to decreased uterine blood flow. Giving low molecular weight heparin improves the uterine artery blood flow and increases the pregnancy outcome. Then come the unknown. Okay, so environmental disruptors are not known, but this is something which I find it very, very useful, is something called as T-shaped uterus or low volume uterine cavity. So low volume uterine cavity is that you do an ultrasound on the day when the follicle is 18 to 20 millimeter, uterine volume assessment, endometrial volume assessment, and if it's less than 2.2 ml, then likely that she will be successful is less. And this is typically seen in patients who have repeatedly undergone a dilatation and curettage. The curating has resulted into a damage to the inner layers of the endometrium, leading to narrowing of the vertical limb of the uterine cavity. And they did a metroplasty for such patients and leading to improvisation of endometrial volume, Look at 80% of these patients conceived spontaneously, and they did office hysteroscopy. Okay, so only thing is that we need to diagnose this correctly and then only subject the patient for surgery. Then comes the role of progesterone. I would always think, may you take dufaston, okay, or digogestrone, okay, or progesterone. And they talked about the TH1 response and TH2 response and changing the TH1 to TH2 all happening, and they recommend that starting these drugs after the conception is happening, okay, in recurrent pregnancy loss. I would take one step back. All these immunological processes are happening around the time of implantation, and hence after the ovulation, giving progesterone helps in correcting these abnormalities. Correcting the balance between the TH1 and TH2 would definitely help in improving the pregnancy outcome, as is shown by this study in 2017. By giving starting progesterone in the luteal phase post ovulation was associated with increased pregnancy outcome rather than waiting for a pregnancy test coming positive. Now, obesity and miscarriage, again systemic meta-analysis shows association between excessive weight gain and recurrent pregnancy loss was significant, and this particular group is something which is very, very high risk for antenatal complications also. So one should know that obesity is an independent candidate or a factor for recurrent pregnancy loss. Vitamin D, anything you compare, vitamin D is associated. Micronutrient, we know that hyperhomocystinemia and defective methylation. So giving L-methylfolate would be useful in these conditions. Another paper, again, I'm talking about the autonomic nervous system, sympathetic versus parasympathetic, looking at heart rate variability and 100 unexplained recurrent pregnancy loss patient with normal healthy couple and mental distress score was taken. What they found that heart rate variability was more in patients with unexplained recurrent pregnancy loss, especially if the losses are more than 4. I think here is the role of the support, mental support, what we offer. So what do we do of a recurrent pregnancy loss patient who becomes pregnant normally? We give little bit of estrogen, little bit of progesterone, little bit of steroid, little bit of SCG, complete bed rest, thoda immune therapy, everything possible, do a cerclage for a first trimester abortions. Low molecular weight heparin. So I think rather than that, maybe this is what if we take care by reducing the sympathetic tone and increasing the parasympathetic tone would help to improve the pregnancy outcome. Well, more and more ART centers are using this now for more than 3 and 4 abortions, which would be the one of the therapies, but I have my own reservation when I has to look at if the candidate really deserves and needs this rather than anything else. When you look at the pregnancy outcome after unexplained recurrent pregnancy loss, they have increased risk of preterm delivery, gestational diabetes, and more after they are delivered by cesarean section. And in children, they seems to have, RPL patients tend to have children who have increased likelihood of epilepsy, developmental disorders, long-term neurological morbidity, and some of the gastrointestinal syndrome like inflammatory bowel disease. At the end, I would like to thank again for my all patients for giving me the opportunity to study them, work on them, and understand the details of pathophysiology of recurrent pregnancy loss. Thank you very much for a patient hearing and the opportunity.
Dr. Reddy, sir. So, Dr. Kader, thank you for giving your own insights and some latest research into the recurrent unexplained pregnancy loss. Sir, ready, sir? Should we have the discussion?
Yes, now. See, in that group, questions are there, Papa, you can see. The WhatsApp group, 28th June, tap is our webinar. In your mobile, it will be there.
Yes, sir.
I have
Dr.
the question.
Geeta?
Can I ask him? Sir, I've seen the questions.
Okay.
Okay. So
can I start with Dr. Kedar? My doubts.
no, there are some questions already, Dr. Papa. Please, you have to first answer those.
Yes, I'm not able to see.
Okay, I can ask the question, sir. In the past 3 months, no stimulation have happened. Going forward from July, same number of patients will get stimulated. Or will there be a dropout? If yes, what would be the percentage of dropout? I don't know who's going to answer this. Kedar?
Nobody will be able to tell about this question. I don't know why he asked.
So
We
it's
don't know whether lockdown will go like this. You start the practice or not.
Yes,
You're
sir.
not going to do.
Yes.
What are the ominous signs in fetal MRI? Maybe Dr. Shanta?
Yes, sir. Actually, you know, this, what are the ominous signs in fetal MRI? Usually your radiologist who does the picture will give you, there will be periventricular, like porencephaly, those sort of things, periventricular leukomalacia around the ventricles. But all these features, we need not get worried because they will be actually reported by the person who is doing the MRI, and then we can take a call. So it looks if it's a CNS involvement, then we'll have to plan accordingly whether we need to terminate the pregnancy.
Dr. Jairani, you can ask now questions. And Dr. Geeta also.
Yeah. What are the medico-legal concerns of feticide and MCDA beyond 20 weeks? I think that's for Dr. Shantakumari.
Yeah. I think, see, we have to understand whatever is the condition where you're going to do a termination of pregnancy, the medico-legal issues are the same. Beyond 20 weeks, still, we have to approach the court, get the okay, and then go ahead and termination. The 24 weeks is still not passed. It's not become it's not come in the gazette, so we have to wait. So even as of now, you have to take the court permission and give them, and they usually will give if it is the condition is mentioned.
Even for 20 weeks, Shantakumari?
Yes, yes.
Even for 20 weeks, you need a court?
Yes, 20 weeks plus we need. Because the 24 weeks which has still not been gazetted. So because of this corona and all, I think that upper house has not met.
No,
so
up to 20 weeks, whatever you are doing previously, you can do it.
Beyond 20,
up
sir.
20.
Beyond,
Okay.
20. Beyond 20. The question is beyond 20.
Okay.
Beyond 20, we have no choice. You have to get the court permission.
No, Dr. Geeta is asking, before 20 also you have to get the...
No. Up at 20. At 20, that's what I wanted.
That's a very grey area. So you have to be careful. You have to get it 19 weeks plus 5 days or 6 days in your ultrasound. No, sir. There is absolutely very clear message. None of you take law into your hand. Follow the procedure. You have to take the court permission and do it. Because there are no two ways about it.
Okay. Madam, what investigations you would do as soon as you diagnose single fetal demise? Because recently we had a case referred after IVF in the anomaly scan. They diagnosed single fetal demise and they have done D-dimer. So I feel D-dimer should not, and they scared the patient.
Dr. Tasari Papa, I think in my talk I have given very clearly the presentation. Where the coagulation profile should be done and how
that is what. Yes, it is very clear. What is the role of D-dimer?
Same, that is your coagulation profile. You have to,
no, there is no role for D-dimer. They scared the patient. Patient refused to go. She got admitted in JIPMA from February, from 22 weeks till 36 weeks. She was kept.
Individualized way of handling the.
Yeah, I don't think we should do a D-dimer. Serum fibrinogen is the one we must do. Serum fibrinogen.
Okay, now moving to the next question. Is it necessary to do cervical circlage for all twins, even if the cervical length is normal? I think Dr. Shantakumari or Dr. Kedar can take this.
And I don't think you need to do the cervical length class for all twins. Now, no longer, because even if the cervical length is perfectly okay, I don't think you need to do the. It used to be, if I remember, 20 years back in the earlier time of IVF and all IVF pregnancies, they used to put cerclage. All twins, they used to put cerclage. So we have moved beyond that, and no longer do we advise cervical cerclage for all multiple pregnancies. So no.
Okay, there's another question. Endometrial fluid, is it sometimes an intermittent event in what? Dr. Rajapriya. I think that's for Dr. Soumyaru. Soumyaru, unmute yourself.
Soumya? Sana, just tell him to unmute now.
Yes, sir.
Am I audible?
Yeah, you are.
Yes, you can answer.
Yeah.
Soumya.
As I had mentioned in my talk, endometrial fluid is sometimes a transient phenomenon. It can be there during stimulation. The important thing to note is when the fluid is, when are you seeing the endometrial fluid? Like suppose on second day, day 2, that is after the patient has had her menses, second day of her menses or third day of her menses, you see, without even stimulating the patient, without even starting stimulation, you see endometrial fluid. It is an ominous sign. If you start seeing this fluid somewhere around the 9th or the 10th day of stimulation, then it is a good prognostic indicator that this fluid is harmless. And simple aspiration transvaginally before transferring the embryos will give you good results.
So there's the next question. What is the most suitable antibiotic regimen for endometritis non-TB type? Non-TB type of endometritis, what is the best drug of choice? That's what has been asked.
Clindamycin.
Doxycycline 100 milligrams, 2 weeks. 2 weeks. Suppose the patient is not tolerating something like ciprofloxacin plus metronidazole for 2 weeks. That is the endometritis treatment. Okay, next.
Another question. Sometimes fluid persists even after bilateral complete self-injectomy. What to do?
This is a very interesting question. I have not actually dealt with this.
I have.
Sometimes fluid still persists after self-injectomy also. And mostly it would be seen that this fluid usually is seen when the uterus is a hypoplastic kind of a uterus. There, fluid still persists. In such a case, what has to be done? One has to go for gestational surrogacy only. And again, like I mentioned in my talk, if the fluid anterior-posterior diameter is less than 3.5 millimeters, then aspiration can be done transvaginally with a IUI catheter or the embryo transfer catheter, and an attempt to release the embryos could be done. But if it is more than 3.5 millimeters after bilateral self-injectomy also, it is better to go ahead with surrogacy.
So I would like to share one experience of mine. I have right now a pregnancy going on, a 30-week twin pregnancy. She had, first time she had a fluid, so we disconnected because she has undergone a TB abdomen treatment, so we disconnected the tubes. But even then the second time IVF, I first cancelled, and second time also, even after disconnection, she had fluid. I aspirated, I transferred, and she's now pregnant with 30-week pregnancy twins. So still, we can go ahead with the transfer. And I feel probably I took the fluid and sent for culture. It's a sterile fluid. So we proceeded with the transfer and she's now pregnant. So there is still a possibility even after self-injectomy, if you have fluid, there are pregnancies which has been proved.
Yeah, I think Jairani share the same experience. But there's one more thing that you have to think of. Sometimes these patients, an MRI will contribute because it can detect junctional adenomyosis, which is one of the causes for a fluid in the cavity. So I think doing an MRI when you can't find any other reason, you've actually clipped the tubes, you have given them enough antibiotics, and still the fluid persists, maybe you should think about that, because we have identified a few patients, treated them with the GnRH agonist, and this fluid stopped coming and they were pregnant.
I think Kedar wanted to say something. Kedar, can you come to the line to answer? You unmute
yourself, Kedar.
The similar finding that it is very commonly seen with hypoplastic uterus, and the same experience that fluid was sent for examination came out to be sterile. So it is not necessary at all that you go on to the higher step. Try with the present situation. Maybe one has to look at if there are, sometimes the tubes may not be hydrosalpinged, but in case of severe PID and tubes are very damaged, then also it can contribute. So clipping would be ideal, but even if there is fluid, one should give an attempt for a pregnancy.
Doctor, my experience in peripheral areas, I always start with ampicillin garamacin IV for 5 days. If I find fluid within 3 to 5 days of estrogen for FET cases, within 5 days the fluid 100% goes. Few of them is still persisting. For them, I used to take the fluid and send for culture. And within 3 days, the culture comes some positive, I give the drugs. And otherwise, linezolid is very good drug. Now I am using very well for all my patients. It's giving very good result. The fluid is going out. Persisting with all these things, again it's not doing. Then I start empirical AKT. They are doing well. This is my experience.
So one more question: how to measure the endometrial thickness in serometrop?
When fluid is there, how to measure the endometrium?
How to measure the endometrial cavity in the presence of fluid? Yeah.
Here, I like to take the answer to this. It is the anterior-posterior diameter, the maximum diameter where you find. Maximum diameter, anterior-posterior diameter.
Just dash here what they are telling, fluid is there, no, that how to take. This you have to take measures separately, anterior and posterior. Then
yes,
that's
yes,
the one thing.
Yes.
Okay.
Yeah, in between the fluid column is there.
Yes, that's why that we have to explore.
So
will you include the fluid column or will you
no.
Exclude.
So basically what I suggest that you start with endomyometrial junction to the posterior part. See, if you're doing the lower part, the endometrial fluid junction, one half, then go to the other half and sum the two. Don't consider the fluid in between. So you will get the endometrial thickness. Am I correct, Dr. Sanjeeva Reddy?
Yes. Kedar. Kedar, one question to you.
Yes, Dr. Kedar.
If patient comes to you with unexplained infertility, just tell me, like, I'm a layman, how to go about just what you are doing in your practice.
See, what I do is I look at the gestational age of abortion, which gives me an important clue where I'm heading. If it's 6 weeks, I know it's likely to be a genetic or likely to be an endometrial blood flow issue. If it's anywhere after 7 weeks, heart sounds have come, it goes in APLA anatomical as I go on. Ultrasound is the most important tool of my investigation, which helps me to rule out anatomical causes, antral follicle count, decrease ovarian reserve. Then looking at the systemic causes like diabetes, then I do a semen test, and then if the patient has 8 weeks, 3 losses after cardiac heart sounds, I will do the APLA test. Okay, so depending upon the type of abortion I get, I will do the evaluation rather than giving the full list of evaluation at one group. If my TVS shows there is no intrauterine abnormality, I normally don't do an hysteroscopy to evaluate the endometrial cavity. That's sufficient for me. If the myometrial junction is uniform, there is no halo around it, so endometritis is ruled out. So one by one step, I go up accordingly.
So when you will advise a karyotyping for a recurrent pregnancy loss, which are the candidates you advise?
Early pregnancy losses after 2 abortions, but I would now, thinking process is changing now. Karyotyping is for maybe knowing at the numerical abnormalities. maybe doing a microarray for product of conception is the new thing on the block, which will pick up the proper, genes abnormality, which we are missing at the moment. I think the microarray is the new technique which is need to be explored in the near future rather than doing karyotyping, because karyotyping is one part. The second part is your gametes. See, if your ovaries are producing bad gametes or your sperms are produced by bad testes because of grade 3 varicocele and diabetes, that needs to be evaluated more frequently than the karyotype.
Thank you. I think there are some more questions, but it's because we'll delay already. We'll stop the session. We'll go to the next session.
Thank you very much, sir.
Okay. Thank you for all the three speakers. I'll request Dr. Kamala Sarvalas to introduce the next session moderators. Dr. Kamala? Dr. Vijaya?
Thank you, Dr. Sanjay. It's my duty to introduce the second batch of moderators, starting from Dr. Sarat Bhatia, MD, DGO, FICOG, Consultant Reproductive Medicine Specialist, Indigo Women's Center, Chennai, and academics, of course. I won't go to so much of details. Yes, completed from National University Hospital, Singapore, under Professor Ratnam and Dr. M.C. Soon Ching, King's College of Medicine, London, under Dr. John Parson, in charge of IVF program in Apollo Hospital till 2016, from 1989. Responsible for the first gift baby of Tamil Nadu in 1989. Responsible for the first IVF twins of South India, 1991. First IVF baby born from frozen sample, semen sample in India. Started post-doctoral fellowship in reproductive medicine at Apollo, and responsible for the guide for PhD program in reproductive medicine, Tamil Nadu, Dr. MGR University. Certified robotic surgeon by Intuitive Surgicals, Strasbourg, France in 2011. Awarded Yugadi Millennium Award by Madras Telugu Academy in 2000 and Young Achievers Award by CI. Okay. Now coming to Dr. Kundali, HOD IRM MMM, Triple M, Kundali, Fellowship Program 2003, Leader Consultant in IRM since 1999, Treasurer Oxy, Treasurer Tapisa, Examiner for National Board and MGR Medical University Fellowship students, invited speaker at national level, publications in reputed journals, trained in endoscopy and ultrasound, special interest in fetal medicine, and of course my friend Dr. Dhanabhagyam, MD OG Art NUH Singapore, Medical Director Sudha Hospitals, Erode, Coimbatore, Salem, Chennai and Madurai, MBBS Stanley Medical College Chennai, MD OG Kasturba Medical College Bangalore. 1995 started Sudha High Tech IVF and Endoscopy Center in Erode and produced the first test tube baby of Erode. 2001 to 2003 Secretary Erode OG Society, conducted many live workshops of laparoscopy, IVF and Foxy MTP workshops, national speaker and chairperson in many IVF conferences, and it's gone somewhere. And
you can read
2005 awards. Let me go there. Awards.
You can see the screen.
Award, IMA 2019 Inspiring Gynecologist and IVF India by Award, Economic Times of New Delhi. Best IVF Center of South India and Emerging IVF Center of India of the Year 2020 to 2025 by Time 21 to Times of India. Yeah, Dr. Dhanabhagyam. Now I hand it over to the moderators to carry on the next session.
Dr. Sarath.
I think the moderators have to.
Yes.
Yes.
Thank you very much for your kind words of introduction. And I'm in your footsteps, ma'am. Thank you so much. And Dr. Reddy, thank you so much for giving me this opportunity to be here today to chair this session. And it's a great pleasure for me to introduce Dr. Prakash Trivedi. And I know him for the past many years. And Dr. Reddy, you are able to hear me?
Yes, yes.
Yeah. And I know him for the past many years. And as his name stands for, no, Dr. Trivedi. Trivedi means he has mastered 3 Vedas in our specialty. One is surgery, the other is the third one is the teaching. He's an excellent surgeon, and he's synonymous with the hysteroscopy and TCRE. And he is a great academician, and he has written so many textbooks, and the volume of the textbooks indicates his knowledge and his vast knowledge. And he has made so many CDs and teaching material for the students. And another important thing is he achieved hat-trick. He became the president of all the 3 prestigious societies of our specialty, like FOXY, IAGA, and ISAR. And I'm proud to introduce him to the audience. And Dr. Prakash Trivedi is going to talk to us on endoscopic surgery for management of infertility or to improve the chances of pregnancy. Dr. Prakash Trivedi.
Thank you very much, and it's a great honor and privilege to share this unique TAPISAR program, and I congratulate Dr. Sanjeeva Reddy and Kamala Selvaraj for a regular base ongoing excellent training. We're extremely happy and proud, not only as an ISAR president, but I'm extremely happy and proud that various chapters of which TAPISAR is totally the front line in terms of education, thanks to efforts of Dr. Sanjeeva Reddy, Dr. Kamala Selvaraj, and all the chairpersons are very well known to me. I'm going to make the morning a little lighter because, it's always better to, so I'm going to have a simplified talk, which will be over in exactly 20 minutes or so. We all remember that initially endoscopy, whether hysterolaparoscopy, was invented to remove pathology and restoring anatomy. So enhancing fertility was one of the main aim in terms of practices of gynecology. Currently, it is gone into radical surgeries, hysterectomies, myomectomies, splenectomies, nephrectomies, and so on. So we have to remember that it's very difficult to balance, but it's very important. Say, for example, the procedure which you are seeing, maybe I must have done 3,000 earlier, and of that there were many referred by ART consultant, and of that, though we had 2,300 plus pregnancy, this procedure now is almost thought to be an ancient history. However, we have to remember that in 2011, the meta-analysis suggested that in PCO there were high cycle cancellation rate, high OHSS, multiple pregnancy, low fertilization. And Abdel Gadir clearly pointed out that with gonadotropin, you can get the same amount of ART pregnancy, but if the patient had a drilled for any indication, the abortion dropped down from 28% in gonadotropin alone, because the LH is high, to 6%. For all of us who have totally given up PCO drill is a futile procedure, and that was popularized by Dabira Shrafi in doing a PCO drill in a patient with FSH which was 1.2 and LH which was 3.4. Anne Balian She came across 9 first trimester IVF loss in PCOS, IVF 6 OHSs, ICCU, 2 pregnancies, 3 blighted ovum, 4 missed abortion. And she got fed up, and then she did a PCO drill and left the patient to herself. For her surprise, she had spontaneous pregnancy and came with 30 weeks of pregnancy. So I think so any procedure has its limitation. So you have to restrict the use. There were phases wherein we enhance the use. Science is meant to understand and change, but it's better to understand and change rather than, keep persisting. Now, these are the 2 things which are shown. This is a dermoid, and this is a cyst. Obviously, all of us know that this doesn't come in the way of fertility at all. But you have to evaluate the patient, the couple, the mother-in-law, their anxieties and tension. Because you will nicely advise that there is no impact on fertility and you can keep it as it is. And you may be surprised, but he does a salpingo-oophorectomy and she lands up to you. So if the ovary is totally normal, of course in today's time we do AMH for any patient. So you have to remember that what should be done and what we should counsel to the patient. I heard a lot of discussion on hydrosalpinx, and this is something which is very interesting. And I didn't interrupt the question answer session because in any case I was to go clear. Bilateral hydrosalpinx classically are more in gonococcal infection, sometimes chlamydia. When we say that we are clipping on hydrosalpinx after tuberculosis, if you ask me honestly, just permit me my ignorance to use the right word, it is pointless. Because in tuberculosis, it's the endolymphatics which are affected in the tubes. So the tube is never dilated. So the tube is never dilated and multiple times it is blocked. It is not going to come in the way of your fertility. So that clipping and all, it's a different thing. Obviously, salpingectomy can be done and clear messages. Cumulative pregnancy rate is 43% approximately. And ongoing pregnancy almost 39% after salpingectomy and a good IVF. Don't bother too much about the AMH being affected because it is not because of your harmonic or your cautery use. It is because of the pathology wherein hydrosalpinx also has infection and inflammation in the ovary. Now, many people do an aspiration. So if you've done an aspiration, you can have 34% pregnancy, 30% ongoing pregnancy when there is no rapid reaccumulation. Last but not the least, most important, few people told about fluid in the cavity. If there is rapid accumulation, and this happens because after we start gonadotropin, every tissue in the, apart from ovary, is stimulated. So it leads to certain amount of exudation. So if you have done just a drainage and if you have a rapid accumulation on that hydrosalpinx which was either clipped, then your ongoing pregnancy rates drops down to 15%. So basically you have to remember that abortion rate is similar, and for most of the laparoscopic surgeon we feel that no surgery which we imagine is difficult. We always used to believe that minds don't read what eyes don't see, what minds don't read. But in laparoscopy, we are clearly aware now that we can go way ahead than what even laparoscope can show. We can have a clear thought process. So I personally believe in doing a salpingectomy. Of course, quite a few time when you are in a bunch laparoscopy with an infertility center, you have to clip some, but I don't believe in clipping at all. Endometriosis is another condition wherein I am a laparoscopic surgeon. I clearly admit that 80% of the laparoscopic surgeries done for endometriosis is wrong. And the first surgery is the best surgery. So you have to understand that if this is a slight modification which we do nowadays, wherein we introduce a little bit of vasopressin in that plane, and knowing very well it is a pseudocyst, once material, And there's another important step which we do routinely after you drain. So again, endometriosis surgery, there are a lot of things. Now we re-inject vasopressin between the cyst wall and the normal ovarian tissue. So this helps us to peel off without much of ovarian tissue coming. Myself, Dr. B.N. Chakravarti, had research many cases of endometriosis to find out whether there is IUI and CUH will definitely give 3 times higher pregnancy rate. Most important is live birth rate and spontaneous pregnancy rate in first 6 months is definitely facility ready. In today's time, just 2 days back, we had a big endoscopy seminar wherein we are almost 4,000 people. And we hardly do any diagnostic laparoscopy at all. So basically it is almost pathological. Again, the same ESHRI guidelines do suggest that if you're doing laparoscopy, you might as well treat it. There are evidence to suggest that when you're doing a cystectomy, if the first surgery is good, don't worry, you're removing the disease. Recurrence is less. Even in grade 3, grade 4, if you're doing a good laparoscopic surgery, you support it nulliparous, unmarried, young, when there is endometrioma, 64% of the patients are below 30 years. So you see to helping it. When it goes to stimulation protocol, there are obviously antagonists is the favored one, but there are a lot of evidence which is gathered currently that a suppression, maybe even after a surgery is done, a depot suppression gives M2 oocytes better and better oocyte quality. This is the study which is the longest, and you will be surprised that today 4 centers in the world, one is Marcello, one is Mario Malzoni, then one is Arno Vatis, and one is Sanjay Patel, which is our own, the largest work of endometriosis, difficult one, is done in these 4 centers. This is an Italian Caucasio study with an 11 years follow-up with equal number of patients of advanced and stage 1 to 2 endometriosis. In 1 to 2, fertility rate though was 49%, average was around 37%. When there was an advanced laparoscopy with associated pelvic pain and many other things which may be a rectovesical for the rectal involvement or the septum behind the vagina which is getting involved with, when a good surgery is done, you have to believe in the ART consultant in your area. If you send to them after a good surgery in stage 3, grade 4, you will get 64% pregnancy rate. What I always used to tell to many of the ART consultants whom I used to operate regularly, 23% of them had spontaneous pregnancy rate. And I asked a couple of them, sometimes you send it for a corrective surgery and they conceive. And ART consultants are very typical. And they told, we are very happy because as long as the patient has conception, we don't have any problem. The rate is maximum in 6 months to a year, and it drops down with age more than 35 years. Now in cavity, I don't think so there is any, this is a cornal polyp, this is a fibroid, this is a polyp. This incidentally looks like miliary tuberculosis. I'm not going to the film because this is not a session wherein skills are going to be discussed. You only have to discuss the inference. This is actually a patient of miliary metastasis. So you have to understand that hysteroscopy is definitely like a tool which is on your fingertip and you can see the cavity. And today, office hysteroscopy has almost replaced most of the other procedures. So all these procedures can be easily done. We have been doing from 1992. We have moved on miniaturization of the optics. The Endoscopic surgery has moved from monopolar to bipolar. There are many other things which we have understood wherein we damage the least. And a lot of laparoscopic surgeons have been popular more because of the association with the ART consultant. On regular basis, most of us go and operate bulk of cases, and we really get the feedback from the ART consultant, which is very encouraging. Coming to fibroids, I'm at least happy that COVID has stopped the controversy of fibroid. Because fibroid, anything was a controversy. You suture a fibroid, it may rupture X, Y, Z, leiomyosarcoma, in spite of our impact and so much of publication. Fortunately, now the controversy is gone on COVID. Of COVID also, we have solved plenty of things, which we will highlight in some other session. Presence of fibroid, PRITs, regardless of the location, can affect implantation. Intramural fibroid impinging the endometrial cavity can have clinical pregnancy rate, implantation, miscarriage, live birth rate, all the things affected. In fact, St. Thomas assisted conception in our own place, we had a study wherein 5 centimeter intramural fibroids were removed prior to ICSI, and there was a rise in pregnancy rate by 14%. Most shocking is in a donor oocyte, when you feel there is nothing and you removed a fibroid. Myself and one good ART consultant from US, we found 50% rise in pregnancy rate, because what happens is, as a gynec, we have not understood fibroid anything, but as a fertility specialist, we have understood everything about the fertility or infertility due to fibroid, which according to me is far from the truth. Intramural fibroid, as I told you, there can be increase in pregnancy rate. There are studies to suggest that except pedunculated, more than 7 centimeter fibroid, and if it remains, it's better to remove that and then take her up for IVF, because doing cesarean after myomectomy is not a big issue, because there's so many people who just because an IVF done, they do a cesarean section. We have at our center plenty of IVF patients delivered. Real good study of 6,087 IVF cycle. Non-cavity distorting fibroid reduced the pregnancy rate by 21%, cumulative pregnancy rate by 15%. So my strong suggestion to all of us as a fertility specialist, let's not conclude anything on a subject of which we really don't know. We ourselves in our research had found that prolactin was raised and there was localized rise in aromatase, which led to rise in estrogen. So there are so many fibroids which can be removed, type 0, type 2, type 1, 3 if interfering with vascularity and peristalsis, fibroids in the upper part, fibroids in the cornu, and all these things we are telling is because we have a referral center of fibroid, wherein we get patients from New Zealand, Australia, UK, USA. With all these places, morcellation is banned, and we do it within bag. And we have poked into, in fact, I got a minister's award for the research on fibroid and their impact on IVF and infertility outcome. If there are previous abortion and raised prolactin, it can be an indication to remove fibroid. So these are the indications. So you have to remember where you may consider removal. Abortions dropped from 41% to 19%. So that can be, I will not go obviously into the technique of fibroid or myomectomy. As far as hysteroscopy is concerned, we are very clear. A cavitary fibroid, once you remove, it gives 67% rise in pregnancy, 2 to 5 centimeter. Of course, most of them have made now 2 to 4 centimeter. Polypectomy, again, depending on its location. Cumulative pregnancy rate 41%. Location of the polyp can really make a lot of difference. As you saw in the film, both side cornal polyp was referred as cornal block, and we removed the polyp, and then she conceived in the next cycle. Septum, secondary infertility, uterus recovers back, but fibrosis doesn't. So secondary infertility, septum incision is better. Obviously, prior to an ART, you may consider removal. All of us know that septum has no contribution to infertility problem. Intrauterine adhesion in India, especially with tuberculosis and MTPs and other infection, it's rampant. Office hysteroscopy and in bad adhesional lysis, we always say that you don't take charge anytime to do a hysteroscopy. You take charge for not perforating. But one important thing which concluded out of the AGL was, no matter how good we made grade 3, grade 4 adhesions back to normal, it doesn't necessarily convert it back to the same amount of pregnancy rate as you would expect, which means that the area wherein you have removed the adhesion, growth of endometrium is not taken place. So there is sufficient place for somebody doing research on endometrial transplant or endometrial regeneration or so many other things which are going on. Proximal tubal obstruction is, honestly, we have so many hundreds, 70% patency in both. One side patency 90%, and probably we have 50% plus pregnancy rate once, and they can conceive again. Spontaneous miscarriage rate, irrespective of what is the cause in hysteroscopic surgery, remains, because there is some amount of fibrosis, and I think so they were discussing about the T-shaped uterus and other thing. There are a lot of people who believe that Caesars was superior to monopolar, and now those people are using bipolar and they feel bipolar is superior. I have 10,000 plus resectoscopic surgeries done, whether it's TCRE, hysteroscopic myomectomy, and 25,000 laparoscopic surgeries done. Energy has impact, but it is not you who are deciding, it's your machine which is deciding. So set the current properly, understand the outputs of the current, and skill of doing hysteroscopy is way ahead than the instrument which is used. So don't blame the energy or the instrument. And it's impossible to get continuously very sharp Caesars which you can use day in and out for any hysteroscopy. Office hysteroscopy, I'm intentionally not going because everybody is aware that it has a great place in today's time when we are talking about this is the proximal tubal obstruction, and you can see how beautifully you can cannulate the tube. And a lot of people used to make a mistake of not combining it. 1997, Cook's Novice Scout catheter make the revolution. So when you are hooking there, in fact, Rishikesh is going to speak next, and I remember many years back in one of the live workshop in Lilavati, he had called because when you don't do a laparoscopic control and when you don't lift the tube, actually you can get perforation. So you have to remember that the other aspects of how you do cannulation is definitely very important, and it gives good pregnancy rate. Cavitary adhesions, of course, as I mentioned, this one was referred to me, one of our past president of ISAR, as an absent uterus. But when we went ahead, even at those time with Caesars, and this I call it as a cervicoscopy. So keep the scope in the cervix, allow the fluid to do the guidance, and you will invariably find a small little area or small little path. And once you have, then this Caesar is sometimes used as a dissector. So you use opening the cavity, you are not actually cutting. And once we did that, then you can see it is going nicely. After that, the hysteroscope went. This patient had 6 pregnancy, 5 immunological pregnancy loss, and in the 6th one, I think so, when we had, this was the cavity. So then we referred to the same IVF consultant to handle the delivery, and then she had a proper pregnancy outcome. Obviously, you can have lots of things. You can have, in a patient of infertility, many treatment done. This was a thing which we found. An IUCD put without their information, a J-shaped hook. This is bones inside. Even a primary infertility who may not give you details. So in quietly, you can always discuss with the patient without any relative, husband or anybody around. So lots of things you can find with a simple hysteroscope. Hysteroscope in our hand, it takes 20 seconds to start it. And a procedure doesn't take much more time. Finally, I think so you have to remember in today's time, all of us are very kind that in spite of COVID, we are having so much of education. all of us are very lucky that we are still serving patients and we have not been affected by COVID. So when it comes to doing fertility enhancing endoscopic surgery, I do remember the statement which Sadhguru repeatedly used to tell, okay, finally what will you do? What you love, or you love what you do? Usually, if a person is intelligent, so he will tell, okay, I will do my level best to do the thing which I love the most. But if you're a genius, you will just exactly do what is necessary for the patient and what is safe for the patient. You have to understand that we all are living only because of the most important single person, that is the patient who is being to conceive. I take this president of Foxy, and whatever Sanjeev does, he has a great scientific touch in it.
Thank you, Dr. Trivedi, for the wonderful talk. You made, with your vast knowledge, you made simple solutions for the
and it's the.
Thank you once again. Dr. Reddy, please.
Okay, I'll ask Dr. Kundavi to introduce the next speaker.
Thank you, Reddy sir, for arranging this wonderful session, and we are proud to be your team. And it's my pleasure and my honor to introduce Dr. Mamta Dildal ma'am, the medical director of the Mamta Fertility Hospital, established in 1992, recipient of several gold medals, and his institute research projects with collaboration of Oxford University. And she's done about nearly 50 publications, lot of awards to her. And we are proud to have Madam to give a talk on mysteries of the ovary and revealed by the ultrasound. Over to you, ma'am.
Okay. Thank you, Dr. Kundavi. Let me just get on to the share screen.
Yes.
Come on, no, I can't. Please come here.
Okay, please switch off your video. Ma'am, please do not switch off your video. Switch on your video and click on the green button of screen share.
Can you see me?
Yes.
Okay, great. Okay. A very good afternoon to all my colleagues here. And I thank... Oh no, I can't move this. Just a minute. There has been a real pandemic of... One moment. Just a moment, please.
Can you ask if they can see your screen?
Can you see my screen?
Yes, ma'am.
Okay. There has been a real pandemic of so many webinars, but when I got this, again, it's not moving, baby.
Okay. Click on the screen. Click on the screen. Yeah, now.
But when I got this call from Dr. Sanjeev Reddy telling me that I should take part in this webinar, for the very first time in so many months, I agreed. So thank you, Dr. Sanjeev Reddy. It was really very sweet of you to have thought that I could be a part of this webinar. And today, I'm going to talk about how marvelous we are as far as our ovaries are concerned. Being a woman, I think many of the people in this program agree with me that they not only provide continuation of our species on this planet, but there are many mysteries in the ovary that are embodied. They hold the powers and the secrets of true human transformation. Making eggs is not the only function of our ovaries. Ovaries produce eggs even while we are little babies in our mother's uterus, and these are released till the rest of our fertile life. And when we look at the follicle dynamics and its physiology, at 20 weeks we have 7 million oocytes, which reduce to about 1 million at birth, and by puberty it's only 300,000. After menopause, there are virtually no eggs left. And if you look at what really happens to the eggs that we have in our ovary, most of them undergo atresia, while only 300 to 400 actually ovulate. In contrast to a male who produces a sperm for 6 weeks and that's it for the rest of his life. Besides being only producing eggs, the most important function of the ovary is that it is an endocrine organ. It produces hormones before, during, and after menopause. When estrogens begin to appear in our bloodstream, one of the greatest miracles of human development occur. It is no mistake to call estrogen a feminizing hormone. This is a complex compound, will make this little androgenized girl and transform her into a woman who's capable of reproducing herself. With menopause, this ovary shifts from a follicle rich in producing estrogen and progesterone to an organ that produces estrogen and androgen. In the postmenopausal woman, the ovary now responds and produces more of testosterone and lower levels of estrogen, that is estrone, estradiol, and the precursor androstenedione. So this is how the ovary from making eggs in menopause turns into making hormones only. So when you look at actually the ovarian journey from a toddler, this little androgenic princess dreams of her Disney-like prince. She goes into teenage, where there are volcanic forces that go and change her endocrine balance. She emerges to be a teenager and then a woman, sexually mature to conceive and have children. And from there she enters menopause, a complete person, a woman who is a visionary, who's loving, nurturing, and understanding. This, my dear friends, leaves us to be always in awe of women. So today, when Dr. Sanjeev Reddy asked me to speak on something, I said, let me speak about the secrets of the ovary in health and in disease, and how this beautiful organ that we women possess is unraveled by ultrasound. So when we look at the components of the ovary and the significance of each, the surface of the ovary is the capsule. Inside you have the cortex, which is filled with numerous ovarian follicles and stroma. And inside in the center, you have the medulla, which has neurovascular connections, and this is connected to the hilum. So how is the ovary studied and examined? Of course, you can visualize the ovary externally by laparoscopy. And if you really want to look into the ovary, you have to make an incision and look into it. But then when you have ultrasound, you can characterize the structure of the ovary. And for example, here, you can not only see the outside, but also the contents of the ovary, which in this case are irregularities and papillae. And of course, when you take this mass out, in this case being a borderline tumor, you can actually see what the ovary contains. So you can see that whilst a laparoscopy gives you only the external ovary, inside out, even before you plan any surgery of any abdominal ultrasound. Then you go into doing a transvaginal ultrasound, where you use a high frequency probe and look at the organ of interest, the transducer being very close, magnify as if you are seeing it through a low power microscope. Once you have done a transvaginal ultrasound, you activate the Doppler. When you activate the Doppler, you can actually see the vascularity in the ovary, and this many a time gives you a clue to the histological diagnosis. Great branching vessels with caliber changes, no bridges, no color splashes like you can see here. But the same thing, if you look at a malignant mass, you have microaneurysms, you have AV shunts, you have dichotomous branching, and you can very clearly make out the difference between a benign and a malignant mass. So let's look at these two ovaries. Here you see a mass and here you see a mass as well. But it's only when you put the vascularity on and you see a regular vascular pattern, you know this is a corpus luteum. And when you look at this mass, you can see that there is a lot of dichotomous branching with an abnormal vasculature, and this was a malignant ovarian mass. So just not only doing a 2D ultrasound, but putting in vascularity into your pattern will give you more information. So when you're evaluating, so first you do a 2D, then you go into a vascularity, and then evaluate the ovary by 3D. And this actually gives you, and I will be giving you you can do a rendered image. You can then use what is called a cine loop, where you look at the ovary completely. You can use different modes like the silhouette mode. You can do tomographic ultrasound imaging, very much like an MRI. You can evaluate what is the percentage of stroma, what is the percentage of follicular tissue. You can look at the vascularity. You can even go step by step by what is called the niche mode. So these are some things that you can do with pure ultrasound, giving you the diagnosis. So in other words, when you are doing a TBS, you are actually seeing the pathology at a very close range. Very much like a pathologist will look at a gross examination. The only difference is that this is the mass that is there on ultrasound. This was after we had excised it, and this is how the pathologist sees it. So a pathologist can only see a gross specimen, but whilst you're doing an ultrasound, you can even look at the vascularity. As in this case, you can see she had papillary masses inside, and that was a borderline tumor. So you can even touch the structures, and it can be a very dynamic interactive examination, unlike MRI or CT. So when you are looking at evaluation of the ovary, let's see how we evaluate an ovary. Yes, there is paucity of time. I just have a limited period of time to speak to you. And so I would quickly go through how we look at an ovary. You look at the volume. You look at the antral follicle count, you look at the stromal component, and you look at its relationship to the different organs in the pelvis and the vascularity. So everything has a reason. So when you measure it either manually or by a vocal, there is a reason why you do so. The normal ovarian volume is between 3 and 6.7, but when you see there is a volume more than 10 centimeter cube, then you know this is a patient who's a hyperresponder. She requires longer down regulation. She requires more frequent monitoring. She requires a lower dose of gonadotropin. Why? Because if the volume is more than 10, she has a 23% chance that she will have hyperstimulation. So just looking at an ovarian volume is going to tell you volumes about how you should treat this patient. If you find, on the other hand, the volume is less than 3, you know she's a poor responder. You know that you're going to get less number of eggs, a lesser pregnancy rate. So when you look at the volume, it is found to be superior to even the day 3 FSH. So just doing an ultrasound, it gives you an indication. Then coming to echogenicity. Looking at the stromal echogenicity, it may be of different stages 0, 1, and 2. Because of paucity of time, I can't go into details of this. But then looking at the stroma, you can actually predict that here, if you see too much of stroma, you know that you must be careful with this patient. She may have impaired glucose tolerance. She has high androgen levels. It is the most accurate predictor of hypo and hyperandrogenism, hirsutism. So just looking at her ovaries, you can actually look at her phenotype. So the ovary gives you those details. Then you put on the Doppler. Just putting on a Doppler and looking at the vascularity of the stromal vessels, you can actually say from the peak systolic velocity, if the velocity is less than 10, you know at the beginning of the cycle that she's going to get less number of eggs. And if you find a very good peak systolic velocity more than 10, you know that you're dealing with a hyperresponder, so you need to be careful with your stimulation protocols. So having understood that this ovary has a volume, it has stroma, it has stromal vascularity, then let's look at what it contains in terms of follicles. The different follicles that you see within the ovary are the primordial follicles. You can't see them. You can see the preantral follicles. Again, you can't visualize them because you need fluid in the follicle for it to be visualized. So you can visualize the small antral follicles, the large antral follicles, and the pre-ovulatory follicles. So what then is antral follicle count? Antral follicle count you are prescribing gonadotropins. Which count is about less than 37, the decline is 4.8% per year. And if she's more than 37, the decline is about 11.7 per year. So looking at the antral follicle and the age, you can actually tell the woman, you know what, you have to be careful. So the antral follicle count, how is it done? You can do it by eyeballing technique. You can do it by what is called the inversion mode. You have the sono AVC, and now technology really destroys us or makes us more dependent on it, and you have something called the sono AVC antral, where you can actually count the number of eggs and you can do your prediction. So why should I count an ovarian follicle? It predicts the ovarian response. You see how predictable women are. This is for the men who are attending this Congress. You can predict the live birth rate, approximately at least. If you have more than 7 follicles, antral follicle count total, the prediction of live birth rate is about 30%. And if you have less than 6 total antral follicles, then it's about 10%. You predict the onset of menopause. If you have less than 4 antral follicles, the risk of the patient has a 3-fold increased chance of attaining menopause in the next 7 years. And then, of course, the risk of aneuploidy. You can also estimate the ovarian age and advise the woman, well, you know what, the number of eggs that you have are less, so maybe you'll think of oocyte freezing. How does this apply to understanding the ovary? We calculate based on the antral follicle count, the vascularity of the ovary, and the ovarian volume. You can actually predict the initial starting dose. Again, it's beyond the scope of this talk to go into the details of this, but there is a beautiful article by Popovic where, you have 5 minutes more? Okay. So I have about 8 minutes more for this talk, so I'll be a little faster. So you can also predict, looking at just these parameters, what is the timing of the HCG. For example, if you see there's a follicle that is mature and the vascularity is good, you can predict ovarian hyperstimulation by just looking at its response pre-stimulation, during stimulation, and again the vascularity. So now let us go into quickly in the next 8 minutes how you characterize a lesion. So this is practically how you do it, and then you characterize the lesion. Why should you characterize a lesion? For a clinician, it is important to know whether if there is an ovarian lesion, is it physiological? Is it a functional lesion? What are its components? If the surgeon is an oncologist, the surgeon wants to know, am I dealing with a benign lesion? Am I dealing with a borderline lesion? Am I dealing with a malignant lesion? What is the type of malignancy? Is it metastatic? If it is a surgeon, I need to know, is it vascular? Is it adherent? Are there intestinal adhesions? What is the status of the pelvic structure? Is there endometriosis? Is it operable? So that is why I need to characterize ovarian lesions. So first, is the ovary normal? I need to find out. Is it a normal ovary? Is it a functional cyst? We know that women who are through a menstrual cycle, the size of the ovary keeps changing and shifting. If the woman is in the reproductive age group, you see approximately 11 follicles, and it may exceed up to 30 to 35. A menopausal woman will have ovaries with a mean volume of about 1 ml. I'm really sorry for being so fast, but I have to cover my time. If it is a functional cyst, you know that one of the most confusing is the presence of a corpus luteum. It can take several. Only significant factor is with the next menstrual cycle, it should disappear. Now, when you're looking at parameters of ultrasound for polycystic ovaries, you can go by the antral follicle, the pattern of distribution, the ovarian volume, the stroma, the vascularity, and so you can make your diagnosis just looking at the ovarian morphology. So when it comes to a lesion, anything that is not normal is considered a lesion. It may be benign, it may be borderline, it may be invasive, it may be metastatic. Now, how do you go about this approach? May I be allowed to just take 5 more minutes? The 3-step approach. The first step when you are approaching a lesion in the ovary is to find the measurements and the terms. Second, characterize it by what is called pattern recognition. Third, the simple rules. The simple rule really means that there are M features which are malignant features, there are B features which are benign features. If you have one M feature, then you call it malignant. If you have one or more benign features, you call it benign. And if you have a combination of both, then you call it in which case you have to go into the next model. Okay. So let's see the preliminary status. You have to have definite features that you use as definition. You must know, is the lesion coming from the ovary, where you see the crescent sign. The second, you have to know, is it a solid component. To call it solid component, you must have, the mass must have vascularity. Is it amorphous tissue? Is it a blood clot? It is very important to know, are there papillary projections? That if it is a papillary projection, it should be more than 3 millimeters. Anything else is considered an irregularity. Is there a septum? Is the septum complete? Is the septum incomplete? These are the features you must understand about every lesion. Is there acoustic shadowing? Is there fluid in the around the lesion? You must measure the lesion in 3 planes before you say it is a lesion. Look at the external contour of the lesion. Look at the internal contents of the lesion, and look at the vascularity. Having done this, you know that there are 5 cyst contents. It may be anechoic, it may be low-level echos, it may be hemorrhagic, it may be ground glass appearance, or it may be mixed. So these are the type of contents. There may be 5 type of lesions. It may be a unilocular mass. It may be multilocular. It may be multilocular solid. It may be unilocular solid, or it may be a solid mass. So why is it important? It is important because if it is a unilocular, the possibility of malignancy is only 0.6%. But if there are solid components, the malignancy chance increases to 37%. And if it is multilocular solid, the chance of it being malignant is very high. So it is very important that you identify early. The next is pattern recognition. Pattern recognition, you know that these are the different people you see. So just looking at her, you know she's come from Tamil Nadu. Looking at her, you know she's from Nepal. So just like this, you have pattern recognitions for ovaries as well. Looking at this, you know you're dealing with endometriosis. Looking at this, you know you're dealing with a teratoma. Looking at this, you know it is a serous simple cystadenoma. And of course, a malignant lesion would look irregular. So these are the dermoid cyst very clearly.
What you want me to do extra duty? That's all, no?
There's some disturbance. So if you have a pattern recognition, a dermoid
every time I suffer, every time. It's okay. I'll do extra. Do you want me to do extra duty? I'll go and speak to.
Can I take another 5 minutes, please? Okay. So the next lesion which you can make out just looking at the pattern is a papillary serous cystadenoma. This is a borderline tumor. The next thing you can make out is an endometrioma, the ground glass appearance. But what is important here, and the take-home message is that you can call this an endometrioma if she's premenopausal, because her possibility of having malignancy is 3.8. But never ever make a diagnosis of endometrioma in a postmenopausal woman, because there the malignancy possibility is 44%. So whenever you see that a woman has had an endometrioma very early in life, please be careful of them, particularly put in your Doppler into these endometriomas. For example, this patient came with an known patient of endometriosis, came with an endometrioma, very vascular mass. Turns out that this was actually an endometrioid carcinoma, as you can see it here. So please be careful when you're looking at endometriomas, even though you can make a pattern recognition. The second is apply the simple rules. Simple rule in this case, you can see that it's a unilocular cyst. And all the feature, there is one feature that it is a B rule, and here this is a patient who has 2 B rules, no M rule, so it's a benign cyst. This is a ordinary serous, it is a serous cystadenoma. So you can see just doing an ultrasound. Now this is a very interesting case. She came in for an IVF program. I did an abdominal ultrasound. She only complained of pain. She was going in for IVF at another center where they were stimulating her. She came for an opinion with me. And I just saw there was fluid, and I couldn't understand why day 6 of stimulation she had fluid in the abdomen. We went ahead and did an ultrasound for her transvaginal, and you can see here the capsule had actually broken, and you could see it was invasive. When I asked her to give me the details, she slowly brings out a paper and she shows me that she was actually a case of a borderline tumor going in for stimulation. And because she had abdominal distension, she came for a second opinion. This was a clear-cut borderline lesion after stimulation going into an invasive malignancy, as you can see. So please be careful with your patients. And there are certain lesions called inclusive masses, wherein you use what is called an Ednex model, where an Ednex model will help you to make out whether it's a benign tumor, a borderline tumor, an invasive tumor, or even a metastatic tumor. Should I stop or can I continue? I've finished 20 minutes.
2 more minutes, ma'am.
Can I go ahead for 2 more minutes, please?
Yes, ma'am.
Okay, thank you. So what you need to do is do an ultrasound, put in the data for the Ednex model, and the Ednex model will actually tell you whether you're dealing with a benign tumor or not. And this Ednex model is available online, and there are no more unexpected results. So you can see the Ednex model will actually give you, is it a benign tumor? Is there a risk of malignancy? Is there a possibility of metastasis? I'll quickly give you a case in which She was diagnosed to have a papillary cyst adenoma, and this head neck model actually told us the risk of malignancy. But more than this is the next case, which I want to tell you. And this was a girl who was an unmarried girl who came to us. When I did a transrectal ultrasound, there was a solid mass there. It was very vascular. I went into the Ednex model. The Ednex, this is a place where I had actually missed something. So that is why I want to put it up for you. The Ednex model told me it was a 20% chance of malignancy. So I put up the possibility that it may be a metastatic or a malignant tumor or a benign tumor. I then went on to do a breast scan, and what she had was a breast intraductal carcinoma. She was a young girl of 24 years who presented only with an ovarian mass. So please be careful. And so the recommendation is, when you have an ovarian lesion, 75% of the time you can use the simple rules and make out whether it's a benign or a malignant. If it is inconclusive, you need to go in for what is called the Ednex model, which will guide you and tell you whether you're dealing with a benign or malignant tumor. So what is my message to you? My message to you is, you are an artist. Your patient is your canvas. Be sure to take properly every image as optimally as possible. Evaluate your images and use the best image you can. Demonstrate anatomy of normal and abnormal. Take the best pictures possible. And remember, the road to a successful diagnosis is always under construction. You need to learn more and more. And it is these webinars that help us. Thank you, Dr. Sanjeev Reddy, for having invited me for this webinar. I'm sorry for being so fast, but I had no choice.
Thank you so much, ma'am, for the wonderful session. Such an eye-opener for us to know that so many modes are available in the ultrasound. And probably, I'm sure you're going to have a lot of questions at the end of the session.
I wish I would.
Amrita, can you stop your sharing?
Yes.
Stop the sharing. Go all the way on.
Yeah.
Can I share my screen? Dr. Sanjeeva?
Next, Dr. Dhanabak, you can introduce Dr. Rishikesh.
Yes, sir. Thank you so much, Dr. Reddy. Being a silent hero of Tamil Nadu Tapizar, you are making all of us to be active in the Sunday morning. And coming to the subject and coming to the introduction of the speaker, there is no need of introduction for the Rishikesh Pai. Pai is known to whole India and international level. And for the just completion sake, I'm introducing him. He is medical director of Blue IVF Group of Hospitals. And initially, I know Dr. Rishi and Dr. Jatin started many centers. They are the people who promoted all IVF in all over India. I can't remember. These two are two eyes, two heart chamber of mine, always in my hearts, both of them. Because they really introduced all over the India IVF and make IVF awareness, and that's why in even villages like us, everyone is now doing IVF with good interest. And he is the administrator Foxy Manyata Initiative, and he is the director Corporate Affairs IFSS International Federation for Societies, Fertility Societies, and he is adjunct assistant professor Eastern Virginia Medical School USA, and he's a postgraduate teacher in gynecology at DNB Examinations India. Not only all this, he is always a teacher in all the conferences. That's why all of our people learned by conferences more with Rishi more than anything in the colleges. And he is a visiting professor in obstetric and gynecology, Manipal University, India. And his interest, no need to say all this, infertility, endoscopy, IVF, ICSI, and whatnot. Finally, dance. Okay, and he is a major awarded with the esteemed fellowship of EDUM of the RCOG, Royal College of Obstetrics and Gynecologists, London, UK. He's a past Secretary General, Senior Vice President, Department of Secretary General, Treasurer, Chairman, Foxy, past President, HR, IAGE, and MOX. And he has no need to tell all his awards. And he is the first fellow who introduced laser-assisted hatching in India. And he is now unanimously elected Foxy President. Over to you, Dr. Rishi.
Properly? Can you hear me? Hello?
Yeah, our topic is there any value of adjuvants in IVF?
Hello.
Sana?
Yeah. Can you hear? Can you hear that, Rishi?
No, your volume is low. Voice is low.
Yeah, Rishi, your voice, please increase your voice volume.
Other phone.
So please on your video as well.
I'm going to
the audio phone on the video. Can you hear me now?
Yes,
Yeah,
better.
yes, now.
Yeah. Okay, now I can't see my screen.
Share your screen.
I don't know what is the problem. 1 minute.
Do you want me to share the screen?
Yeah, 1 minute. Okay, 1 minute. One minute, I'm nearly through. Okay. Can you see my screen?
Yeah.
Put in the slide mode. Slide show.
Dr. Rishi, yeah.
Just trying to, yeah, okay. I'm going to now talk to you about a very difficult, I had a real tough time doing this talk, so you have to give me 5 more minutes. I've sat up the whole night getting the talk together. And so what is adjuvant? So, there's a beautiful article, 4 articles are there in Fertility Sterility 2019 by lead Cynthia Farquhar, and she defines adjuvants as adjuvants are add-ons, are additional treatments other than the standard IVF treatment, which are offered to the patients to improve their chances of success.
Why switch on your video also? We want to see you.
Oh, video. 1 minute.
So you are visible. Your audio is on.
Okay, no, audio is on. Okay, I'll
Video,
just
video.
this.
Video alone.
Okay. I will have
you
to
can
just
see.
put it like this. Can you see me?
Yes.
Yeah.
Okay. So if you look at the how do you introduce an adjuvant? So the ideal way is to do hypothesis. You create a hypothesis. You do animal testing. You do research on donated human gametes or embryos. Then you do the initial clinical trial. Then you do RCT, systemic reviews, meta-analysis, and then the meta-analysis has to have a power. You need to have 2,000 patients to have a 5% improvement of live birth. So you have to prove that. On the other hand, actually what happens in reality is that there is a standard practice where you start the study, but there is no time for the planning of the studies, the larger studies, and before the results of such trials become available, these interventions are firmly entrenched in routine practice. So by the time, after 5-6 years, the studies come in, you are already doing your practice. So what is the downsides of adjuvant? There is no improvement in success rate and outcome. And it is costly. For example, the time-lapse system is very costly, can cause discomfort for example, endometrial scratch. It is time-consuming and tedious. For example, endometrial receptive assay, it's harmful to patient. Sometimes if you give steroids, you can have side effects. Harmful to the embryo. If you do PGTA and there is a lot of false positives, so you may have a normal embryo, which you may consider as abnormal, and you may discard the embryo. Then you have psychological trauma if the couple fails to achieve pregnancy, and ethical dilemma. You yourself may feel, oh, am I offering the correct treatment when I don't know whether it will work or not? So the ideal way would be what? You collectively invest and support and collaborate a multi-centric large trial, wait for the outcome of the trial, and either not and don't offer the add-on, or if you actually offer the add-on, you offer it as a research project and don't charge for it. Patients should be advised to save the money by avoiding add-ons and go for additional cycles of established treatment at lower cost instead of inflating costs of a single cycle. So ideal way would be, if a patient still wants to, she says, no, doctor, I want the add-on. Then the following strategy can be followed. Add-ons may be offered when there is a little or conflicting evidence, provided information about the current state of knowledge is given to the patient. When there is no evidence of safety or efficacy, the treatment should be offered as a part of research, as I told you. Some regulatory bodies are there like HFEA and the Victoria. I was actually trained in Melbourne. I did my fellowship in Melbourne, and that comes under the state of Victoria. And they are having in oversight, means they have laws, and there in HFEA they have created a traffic light system. So they have green, amber, and red. Green means evidence of clinical effectiveness and safety is there in an add-on. Amber is evidence of conflicting. You don't know whether it is there or not. And red is evidence of clinical ineffectiveness. So in private, what would I do if a patient comes to me? In privately funded countries such as USA or India, self-regulation with proper informed consent, covering knowledge about success rates and limitations of the technique with minimal charges to the patient would be the ideal way to implement. In fact, I was talking to someone in England, they said, Dr. Pai, you must not charge. If you are not sure about the add-on, you should not charge ethically, but you can't not charge. So you can, I have modified it and said minimal charges to the patients can be given. Adjuvant therapies, always keeping in mind the two ethical principles of beneficence and malfeasance. Beneficence means whatever you do, it should benefit your patient. And malfeasance means whatever you do should not harm the patient. What are the indications of adjuvants? One is to improve semen parameters in idiopathic oligospermia, improve ovarian reserve in poor responders, improve endometrial thickness in patients with thin endometrium, improve chances of pregnancy in recurrent implantation failure, and finally reduce the time to pregnancy. So these are the objectives. If you look at male add-ons, there are many male add-ons, but in clinical area, the two main ones are the antioxidants and the sperm DNA fragmentation test. If you look at the antioxidants for male, as you know that there is an increase in ROS in subfertile males, which results in oxidative damage, and there are a lot of antioxidants that are there like vitamin E, vitamin C, carotenoids, carnitine, coenzyme Q, cysteine, folate, selenium, zinc. And there is this one important study which was done by Tremelin in 2007, and he showed there was a slightly increase in high live birth rate was seen. This was in Cochrane 2019. However, number of patients is very small, and overall there is no role of antioxidants in the male. And the color given by the HFA to this add-on is amber, means it is middle. You don't know whether for sure it is there or not. The HFA is so bad now, they have not given a green color to any add-on. They are really khadus people. But anyway, so if you look at the sperm DNA fragmentation, it is again, we all know that if the fragmentation is more than 30%, the chances of pregnancy are very low. However, the British Fertility Society and ASRM has said that the current method for assessing sperm DNA integrity does not reliably predict treatment outcomes and hence cannot be recommended routinely for clinical use. In my clinical practice, if there's a high DNA fragmentation, I'll give antioxidants for 2 months. Following that, I'll do a repeat DNA analysis, and if it is okay, fine. If there's a very severe OAT and if there is a varicocele and there's a DNA fragmentation, I would correct the varicocele. And if despite of that, if the DNA fragmentation is high, patient has a lot of recurrent failures, I would go for a testicular aspiration of the sperm and do the injection. Coming to the female adjuvant. So if you look at the ovarian adjuvants, we have the antioxidants for the female partner. Then we have the three main things for poor ovarian reserve: DHEA, testosterone growth hormone. We have the intra-ovarian autologous stem transfer and intra-ovarian PRP. If you look at the antioxidant, there is no statistical significant difference. There are a lot of antioxidants which you can give: N-acetylcysteine, vitamin A, vitamin C, vitamin E, vitamin D, vitamin B complex, folic acid, myoinositol, coenzyme Q, zinc, selenium. And these are the 4 RCDs which I have enumerated on L-arginine, CoQ10, vitamin D and vitamin B. However, the HFA is given red color to this, means there is no role. But having said that, if a patient comes to me, I will put them on this add-on, knowing fully well that there is no role, but there is no harm as such. So it is okay to put the add-on. If you look at the 3 main medicine which we use for poor ovarianism, DHEA, testosterone, there are a lot of studies that have shown that there is an improvement in live birth rate with DHA pre-treatment, and we normally give DHA in the form of I actually introduced DHA in India. In fact, Ovaris is a product which I told Sun Pharma to manufacture. I used to import DHA from Royal Chemist. I used to smuggle it in and give it to my patient. Micronized DHA is 25 milligram 3 times a day. Then I told Mr. Purandare one day when he came to Lilavati, I said, Purandare, you must get this product into India. And that's how we got Ovaris into India. So DHS is very good. And there is always some RCTs which will say that there is no statistical significance. But in my practice, DHA, again, testosterone, we started using testosterone many years back. So I used to use that Sarnoj gel. I used to cut it open and I used to divide it into 4 parts. And I used to tell the patient to keep it in the refrigerator and apply 1 part every day. So testosterone 2 weeks prior to the stimulation protocol. As you can see in this Cochrane review of 2015, the pre-treatment with testosterone was associated with improved live birth rate. Again, the color given by HFA is amber to both these, and even the growth hormone which we use in our practice. So we use this combination of DHAs for 2 months, and then in the cycle prior to the stimulation of poor responder patient, I'll start the testosterone and I would give the growth hormone during the stimulation itself. Again, the color given by HFA is amber to this. Then the intravenous platelet-rich plasma. Again, it is for when there's a desperate patient, everything is failed. It has hardly any role. Recently, I was in New York, I was attending a lovely talk, and Antonio Pellicer was giving his talk, and he said there is, he had tried everything under the sun. He said it's not worth it to even inject stem cells. If at all, PRP you can inject, and one of our patients is now 28 weeks. We had injected PRP in the ovary, and she is now about to deliver. If you look at the clinical part in the endometrium, what are the adjuvants in the endometrium as far as the female are concerned? Screening hysteroscopy, endometrial scratch, endometrial receptor assay, intrauterine SCG, intravaginal or cervical seminal plasma, intrauterine GCSF, intrauterine PRP, intrauterine stem cells, uterine artery vasodilators, aspirin and heparin. So I'll just quickly go through it. So screening hysteroscopy is very important. Initially, we had some reviews which said that the screening hysteroscopy is good, but the new review that came in 2016, INSIGHT study and the Trophy trial in both in Lancet in 2016 said that overall it is not as good only in patient where there is 2 failures and a difficulty in previous embryo transfer. Maybe in those patients you may use a screening hysteroscopy. In my practice, before the frozen transfer, first transfer I do nowadays, and I do it blindly, unless of course there's a pathology, we'll do a hysteroscopy. But if there's no pathology, second transfer I tell them no. Before the second transfer, I will definitely do. Or if there are 2 failures, I will definitely do a hysteroscopy before the transfer. If you look at the endometrial scratching, endometrial scratching is a technique used to disrupt or injure the endometrium, and it is the most common add-on in the UK in 2016. It was the most common add-on in the UK, and 27% of IVF cycles in 2018 in UK did endometrial scratch. That is people before the transfer. And this is the Cochrane review that has come, Nastri et al. 2015, that there is possible benefit from endometrial scratching before IVF with subgroup analysis suggesting the procedure may only help women with recurrent implantation failure. So the color that is given. Recently, there is a new trial in Lenson et al. In the New England Journal of Medicine. She says she has done 1,300 women and there is no difference in the outcome. So there is a lot of controversy on endometrial scratching, and the HFA is given amber color to this add-on. If you look at intrauterine PRP, it can be done for 2 things. That patients who are not developing endometrial thickness, you can do PRP in them, as well in patients who have recurrent implantation failure. And there are 2 studies. One is by FTKR, which has shown no statistical significant difference in ongoing pregnancy rates. But this I disagree with, because whenever I have a patient of frozen transfer, and if the endometrium fails to develop, as a last resort I use PRP and I get very good results. So I don't agree with this the only RCT for obesity significant higher clinical pregnancy rate. But the color given for this add-on is still amber. If you look at the endometrial receptivity array, this is one of the most controversial tests. More than 66,000 tests have been done, but in order to do a proper study, we will need 400,000 US dollars as an independent investment. I was just reading the fertility study and they said this kind of money cannot be used. And there is only one single RCT by Simone et al. Simone is the one, Carla Simone is the one who discovered ERA test. So his study is there, but there's a lot of controversy. I don't have the time to tell you about why the ERA test has its own shortcomings. The next is the uterine artery vasodilation, and you have the vasodilators like sildenafil, L-arginine, and they cause uterine vascular relaxation, increase the blood flow to the uterus and the endometrium, resulting in thickened endometrium. And there is this study by Gutara, Wishes et al. In 2018, Cochrane review is there, which says that the results report increased endometrial thickness and suggest that they may increase the chance of pregnancy in women undergoing IVF. However, there are a lot of adverse effects. You see, many of the people abroad, they give it orally, not vaginally. And there are adverse effects like headache, tachycardia, flushing, etc. If you look at the two main things that we use, aspirin, it's totally red. FHFA is saying there is no role of aspirin. There is a new trial that has come in, which is it is by Siristatidis in 2016, which shows that there is no evidence to support aspirin. And in heparin also, there is a trial that has come in again by Sheshadri in 2012. So there were two meta-analyses in heparin. One was by Vidya Sheshadri, Sri Vidya Sheshadri, who is a good friend of mine. And she showed that heparin treatment was associated with no statistically significant improvement in live birth rate. But there was a meta-analysis which was made by Poddar in 2018, and he showed that there were three studies. In one there was thrombophilia, in the other two studies there was no thrombophilia. So in the study where the combination was there was improvement. But when only the unexplained recurrent implantation failure studies were considered, there was no difference in the outcome. And the color given by HFEA for both the aspirin and the heparin add-ons is red. Of course, in my practice, I use both of them. I use aspirin as well as use heparin in my practice extensively. I'm one of the pioneers in starting heparin in the country, and I learned it from one of the great guys in England. One of my patients had come from England many years back, and then I saw him. I said, what is he giving heparin? Let me also start giving. Once one patient had come from Paul Devroy. She was giving coenzyme Q, and she was 43 years old, and she got many eggs. I said, what did you get? What did Dr. Devroy give you? She said, he's giving me coenzyme Q for many years. That is the way I started using coenzyme Q in my practice many years back, before even all of you had heard of the coenzyme Q. If you look, other thing is intravaginal cervical seminal plasma. You can apply that, but there is no clear evidence of live birth rate in this. Or intrauterine human chorion gonadotropin also can be given. However, in a meta-analysis, Cochrane review meta-analysis of 17 RCTs, they found that in women undergoing cleavage stage embryo transfer, an HCG dose of more than 500 units may increase the probability of clinical pregnancy and live birth. You know, coming to the immunotherapies, there are multiple immunotherapies: steroids, IV globulin, subcutaneous GCSF, intralipid, leukocyte immunotherapy, TNF alpha blocker, tacrolimus, and intrauterine insemination of peripheral blood mononuclear cells. All these are all red. I used them in my practice, but they are red. They have there is no benefit. There is a study by Busama in 2012 Cochrane review is there, where he has shown no benefit of steroids. In fact, you have to counsel 4 things. You have to counsel the patient, that you may have a, recently, 1 year back, I got a phone call from a patient. She said, doctor, you had given me steroid and I got avascular necrosis of the femur head. I had to do a hip joint replacement. I was really shocked to listen to her. So you have to, and there is also problems of oral cleft lip palate with them. Congenital malformation may occur. So you have to, if you use steroid, you have to be very careful and you have to counsel them well. Same is the thing with intravenous immunoglobulin, and there is no clinical benefit. This is a practice committee, ASRM time report of 2018. In fact, there's a lot of adverse reactions, including tachycardia, thromboembolic complication. I'll never use it. See, I have a dictum. I will never use anything which will make my patient die while doing treatment. So I have a dictum. I'll do everything, but no risk to the life of the patient. Intralipid is again the same. It is red, and it is again. Can you hear me well?
Yes, yes.
You can hear me?
Yes.
Okay. So intralipid, again, the side effects are jaundice, hypothermia, systemic candidiasis. But by the way, this is very funny. When I was in Delhi 12 years back, one patient came from London and said, "Doctor, I have come for intralipid." I said, "What is this? I have never heard this before." 12, 13, 14 years back. I found out what is intralipid, and she said, "I want to get it. Will you give it to me? Because my doctor in UK has told me to give it to me." And that's how I discovered the intralipid. So I use it in my practice, but there is no basis for using intralipid. It is, as far as the HFA is concerned, it is useless, and the side effects are jaundice, hypothermia, and there is one patient who had systemic candidiasis, and she lost both her babies at 24 weeks pregnancy. Again, granulocyte colony stimulating factor (GCSF) again can be used intrauterine, and there is a possible benefit from GCSF perfusion on the probability of clinical pregnancy, especially in patients of recurrent implantation failure. Then this is by Zhang et al. 2018 meta-analysis of 10 RCTs is there. And transvaginal perfusion may be significantly associated with higher clinical pregnancy rates by Lee et al. Again a meta-analysis in 2017. But HFE has given red color to this as well. Though I use it for thin endometrium very effectively, but GCSF and PRP we are using for also recurrent implantation failure where the endometrium is normal. So we are also using for RIF patients. Now coming to the final talk, very quickly I will cover it. The adjuvants in the lab, and these are very important. So you have sperm selection techniques, then IMSI, oocyte activation with calcium ionophore, time lapse, embryo selection with AI, PGTA, non-invasive PGTA, assisted laser hatching, and hyaluronic acid for embryo transfer, which is also called embryo glue. So if you look at sperm selection technique, there are three techniques. You have the PIXI, you have the zeta potential technique, and the MAC. I use the MAC and PIXI a lot in my unit, and I also use a technique called microfluidics. So I use this new technique to harvest good quality sperm. A Cochrane review of 8 studies using different techniques have been studied by McDowell in 2014, and she did not report any increase in the likelihood of live birth. Then if you look at the IMSI, again there was a Cochrane review by Tixera. You know, IMSI is when you have sperm injection at 6,600 times magnification. Tixera et al. Had in 2013 had shown no improvement. However, there was a big review that has come in 2019 by Duran et al. Met, and he had 9 randomized controlled trials evaluating 1,600 patients and 15 observational studies. So he had a combination. So when he did the meta-analysis that included the randomized trials, there was no difference in the live birth. However, when he did the meta-analysis of the observational studies, he showed a significantly higher number of live births in the IMSI group compared to the ICSI group. So these are important things to note before you jump to conclusion. I get sometimes patients, they say, "Doctor, हमने ICSI किया और fertilization ही नहीं हो रहा." We did ICSI, the oocyte didn't fertilize. Immediately I do oocyte activation for them. So we do the ICSI and put them in calcium ionophore for 15 minutes and then transfer them. They get fantastic fertilization rate. So I use artificial oocyte activation a lot in my practice, especially if the patient comes from outside with a failed fertilization following ICSI. The HFA state that oocyte activation with calcium ionophore may improve fertilization rates in ICSI cycle where failed fertilization has previously been observed, and the color given is amber. So if you look at the selection techniques that are there are 3 selection techniques: time lapse, PGTA, and non-invasive PGTA. So if you look at the PGTA, we have the the embryoscope, Of course, it is costly. It is not proven in its outcome, and there has been a study on that by Armstrong and Fakar in Cochrane in 2019 review, and they compared it to so they concluded that there is insufficient evidence of differences in live birth, miscarriage, stillbirth, or clinical pregnancy to choose between time lapse, that is embryoscope, with or without embryo selection software and conventional incubation. So once you have the embryoscope, now the new thing has come, that is the artificial intelligence and imaging has come. So I am already onto it. I have already bought 2 artificial imaging softwares, and you can actually take the photographs of the blastocyst, and automatically by artificial intelligence and deep neural thinking, the computer will grade the blastocyst. So if you have got 4 blastocysts, they'll say this is the best one to put in, and this has the highest chance of euploidy, and this is going to be the new future. So this is coming in a big way, and this is one of the ones which I'll be using. It's called ERICA, Embryo Ranking Intelligent Classification Algorithm, and this is a cloud-based technology which can give you 80% accuracy of selecting the best embryo for transfer. Finally, if you look at the pre-implantation genetic testing, nowadays we do trophectoderm biopsy and do the analysis by NGS. I don't have to go through it. It's just so NGS analysis. And this trial, that was Santiago Mune, is my very good friend for many years. He was my teacher when I did my masters in United States way back in 2006, 2008. And Santi has done a study called the single embryo transfer of euploid embryo. It is known as the STAR trial. It is a big randomized control trial where there were 661 women. There were 2 arms, 330 where he subjected them to PGTA, and 331 where he did morphological analysis. And there was no difference in outcome in the 2 arms in women less than 35 years of age. However, in women more than 35 years of age, there was 14% increase in the pregnancy rate in the arm which underwent the PGTA. So the main application of PGTA has to be for women more than 35 years of age. The overall miscarriage rate in both arms were also the same, 10%. So it is the new thing that has come in after PGTA is the non-invasive. So you can actually take the culture media around the embryo, and the DNA that has leaked out, you can actually amplify it and then analyze the DNA. This we have actually started doing in our lab. I've done 70 embryo analysis, and we have compared it. So we biopsied the embryo as well as at the same time we did the analysis of the DNA in the culture media, and we compared the 2. That is called the concordance rate, and the concordance rate is nearly 82% in our group. The last thing I wanted to talk to you was assisted hatching. I started it in 1998, and there are a lot of studies that have come in which have shown, the Carney study of 2012 has shown that there is it was 31 RCTs and there was no difference in outcome. Only the subgroup analysis said that in patients who had previous failed attempts of IVF, there may be a slight improvement in the pregnancy rate. But recent study by Lee et al. In 2016 has shown that there is no difference in live birth but a small increase in multiple pregnancy rate, because when you do assisted hatching there can be monozygotic twinning, so the multiple pregnancy rate may go up. However, the HFE has given red color to this. If you see the final thing about hyaluronic acid, embryo glue has been, there is a new study, 2015 Cochrane review has come, where the hyaluronan improved the live birth rate with the intervention. Odd ratio was 1.41. However, multiple pregnancy rate has also gone up. Hence, if you use embryo glue, you should do single embryo transfer. You should not even do double transfer. So, coming to the final summary, what are the indications of adjuvant? So, what I will use in my practice. So the first indication is improve semen parameters in idiopathic oligospermia. In my practice, I'll use sperm DNA fragmentation test. I'll use antioxidants, and I would use TISA, micro TISA. If there's a severe oligoacidoteratospermia, multiple failures are there, I would go bypass the epididymis and remove the sperm from the testes. If there is ovarian reserve in poor responder and they come to me, what will I use? I'll use DHEAS, testosterone, growth hormone. And I would use it as a last resort, because some people are desperate, I would use an intra-ovarian PRP. If there is improved endometrial thickness in patients with thin endometrium, what would I do? I would do a hysteroscopy. I'll give antibiotics. Sanjeeva Reddy told you, Doxy I give 1 BD for 21 days. Lactobacillus I have been giving for 15 years. So I give lactobacillus so that I cover, because 90% of the endometrium is covered with lactobacillus. I will do endometrial scratch, estradiol patches to bypass the liver metabolism. If that fails to improve the endometrium, go for GCSF. If that fails, PRP, give aspirin, arginine, sildenafil, and heparin. If there is if there is a patient of recurrent implantation failure, what would I do? I would start them on both mother and father on antioxidants. I'll give them antibiotic just blind. I would do microfluidics and MAC for harvesting best quality sperm. If there's a recurrent ICSI failure, I'll do IMSI for these. If there's a previous failure of fertilization, I'll do calcium ionophore oocyte activation. I would use an embryoscope to get better quality embryos, or if you don't have embryoscope, a benchtop incubator with reduced oxygen tension. 5-5-90 or 5-6-89 mixture should be used. I would vitrify the embryos. At the time of thawing, I would also grade the embryos using artificial intelligence, which I will be installing now in my. I would use a PGT aneuploidy biopsy technique or a non-invasive technique also to get an idea about the genetic status of the embryo. I would put a GCSF PRP, and just prior to the transfer, do a laser etching, do a double transfer. I do a day 3, day 5 transfer. Put her on aspirin, heparin, intralipids, and if suppose she becomes pregnant and the fetal heart starts falling down and goes below 100, I would add on a steroid. And if you want to reduce the time to pregnancy, so what I'm going to do after COVID, now I've taken a decision. This is the final decision between me and Nandita. We discussed about it, and we said, when we go back, what we are going to do? First and foremost, I will never transfer more than one. So I will, when I go back, I'm determined that I will do analysis of using artificial intelligence. I'll do non-invasive testing. I'll tell my patient, I am going to put only one blastocyst in you. First time, if you come first time. If that fails, and I'll do freeze-all. I'll do freeze-all and put the one euploid blastocyst transfer and using AI and non-invasive PGTA. And I would also do a personalized real-time ERA. What is a personalized real-time ERA? We have got a non-NGS system in-house now. If you are doing a ERA, what do? You take the biopsy and send it to Spain. No, we will do that. We will start the progesterone, and on the day 3, we will put the catheter and take out the people biopsy and send it to our NGS system in-house, analyze it and see what is the receptor status of the uterus. And if the receptor status is good, we will thaw the embryo and transfer it. So we will do a real-time ERA. That is what we need to do. So this is the last slide. There was this patient from Norway. She was 37 years old, 17-year married. She came to me 2 years back. She had undergone total documented 9 ICSI cycles. 1 in Denmark in 2003, 2 failed in Denmark, 4th, 5th, 6th cycle failed in Norway, 7th cycle failed in London, 8, 9 cycles failed in Sudan. What did I do? We did 2 cycles. I said nothing doing. So now this is another thing I was telling Nandita. I said, Nandita, from now on, we are not going to do the transfer unless we get 6 to 8 embryos frozen. That's it. We are not going to do it. We will offer the patient at cost price a cycle, but we want the second, we want the embryos in the tank. So we will, so that's what I did with this patient also. First time I got only 6 eggs. I said, no, I'm not going to do, because I had to do micro DC. Rupin Shah was flying down to do the micro DC. I said, no, I want a second cycle. I froze the eggs. I did a second cycle. After that, I thawed the eggs and did the micro TC and created 8 embryos. After that, we transferred the embryos. She became pregnant but aborted at 12 weeks. Then again, she came back. We did the prime the endometrium, put PRP, GCSF, did laser etching, did double transfer, put her on aspirin, heparin, steroid because she had a miscarriage in the previous pregnancy and she achieved pregnancy and delivered at 9 months. So this is how, this is the Ajmer Sharif. This is in Ajmer. Why it is important? I always show this because Akbar, our emperor, was not having children. He went to Ajmer and he went to the Baba, and you know something, in the, of course now everyone has got, the results are great and there's no difference, but in those days I was having very good results. So I went to Tirupati and shaved my head, and I went to Ajmer Sharif and I took the Chaddar also at that point in time, and it was because I was very passionate about my work, and it was that, you know, all this accumulated, the vitrification came in the first, when I got it first in along with Muhammad Ashraf. Vitrification gave us the power of pregnancy. That is the whole key to the success of IVF is vitrification. Thank you very much.
Unmute Dhanabhagyam. Mike. I just stop sharing.
Yeah, can you hear, sir?
Yeah, just stop sharing. Sorry.
Why? Okay. As we are running out of time, just ask each speaker 2 to 3 questions. Then we will go to the next session, please.
So we have taken a lot of time. I said we have taken a lot of time, Sanjeeva. We are happy, even if you don't have to answer any question.
This is to Dr. Trivedi. So when you have a recurrent polyps, what would you do? Dr. Trivedi, recurrent polyps, what would you do?
Yeah, we have recurrent polyps. Important thing is you remove as much as 22 polyps from a cavity, and then the patient is conceived. The only important thing is polyps, you have to be very clear that you keep enough amount of endometrium. Once you keep enough amount of endometrium, preferably use scissors, don't use much of electrocautery, then even with recurrent polyps you can work out.
This question to Dr. Mamta ma'am. Ma'am, when we don't have this high-tech machine, because it is so lovely to see what you are doing, what are the basic things you would tell us to see on a day 2 ultrasound? Ma'am, can you unmute?
Thank you for that question. It's not the day of the ultrasound that you are doing the diagnosis. Whenever the patient does come to you, there are some basic rules to be followed. Number 1, do a transabdominal ultrasound because you need to look for ascites, if it is there or not. And it's only if the fluid is above the pelvis, you call it ascites because that has significance. The second is you do a good transvaginal ultrasound. And in addition to doing it, you do a Doppler study. If you have a possibility of doing a Doppler on your machine and you do a good 2D ultrasound and concentrate on the lesion that you see from outside in or from inside out, that's all you require. Once you do that, then you can use whichever method you want, whether you want to use the benign features, the malignant features, the classification, whether you want to go into the IOTA-EDNEX model. You can virtually do everything with just 3 parameters. A good transabdominal ultrasound, a transvaginal ultrasound using a high frequency probe and a color Doppler. That's it. Everything else is to make you feel better and more complete when you're doing an ultrasound for this patient.
Ma'am, sometimes we see a persistent fluid in the POD.
Yes.
What is your take-home message on that?
Depends on which type of, which cycle, day of the cycle you're seeing it. For example, if you have on day 2, when you see fluid in the pouch of Douglas and it is hemorrhagic fluid, you can be rest assured that you may be dealing with retrograde flow. When you're seeing it at the time of ovulation, that's what you have to see. Now, if you are seeing it with a lesion and that little amount of fluid is there, it could mean something as simple as nothing at all. Or it may have significance of some form of infective pathology. If you see it with a patient with pain in the abdomen, it could be anything from an appendicitis to a rupture of a cyst. So it depends upon how much of fluid you see, what is the echogenity of the fluid that you see, is it associated with pain, what is the volume of the fluid, and what is the type of lesion. So it depends on many things. It's not just seeing fluid. It should be the reason for why the fluid is there. And if you find no reason, you just pass it off.
Sharath, unmute your mic and ask questions.
This question is can we combine oocyte retrieval with laparoscopic salpingectomy?
I saw that question and the answer is very clear. if you have hydrosalpinx and if you stimulate, apart from the follicles developing, the hydrosalpinx also get stimulated. So, as a policy, the salpingectomy should be done prior, and then you do a oocyte stimulation. It will give better results. And we had even one case of a unilateral hydrosalpinx, which is extremely rare, wherein we removed and then there was twins. But no point in doing simultaneously, because if you're doing stimulation along with hydrosalpinx, toxic fluid is already there, and there may not be the benefit that you actually want.
We are going to transfer the embryos in the next cycle. Frozen transfer.
Yeah, what happens is the embryos depends on the oocytes, and the oocytes depends on the milieu. So when you have hydrosalpinx, you have stimulated there is inflammation in the tubes, there is change milieu in the ovary, the oocyte, the endometrium. So even if you're going to transfer as a frozen, it is better to do salpingectomy first, then do a proper stimulation, because then the ovary is devoid of any side effects of the so-called toxic material. The endometrium is devoid. In any case, you might freeze it. That is not a problem, depending on the AMH and the age and all. But stimulating, then removing hydrosalpinx, then doing a transfer is acceptable. Still better is remove the hydrosalpinx first and then do a good stimulation and then do the transfer as it suits you.
Rishi, last question. Is there a report, case reports or anything you have increased results of intra-ovarian injection of PRP?
I told you, Dhanabhagyam, we have done one first patient and she is pregnant now, nearly menopausal.
Yeah, but what was her AMH? What was her AMH and how many eggs she had after your PRP? How many you had and how she's pregnant?
We have very few eggs because actually it was done by my assistant, the PRP injection in Gurgaon.
How did you do that?
Laparoscopically, we did it because I don't like to do it transvaginally. Because we started doing transvaginal because the ovary is so small where we don't know where we are going. So because we want, and the second thing, I always get worried that when I put the needle through vagina and inject something inside, there can be pus. I've had two patients who one nearly died because of ovarian abscess, and second patient. So if you put, especially when you are doing pickup, you put the needle, because you are not using the antiseptic, you put the needle through the vagina, you will introduce the infection. So we never do it as it's a dictum for us. So laparoscopically we will put it, because it will go in, you have to put 5 ml in each ovary. So there is a new technology, because I was in England, US, and I was listening to the new technique what they are evolving. What they are saying is that
you did embryo pooling also for this patient, embryo pooling, because you had less
afterwards. So but what this technique is, the technique is that the cutting of the ovary, it itself cuts the hippo. There's an axis called the hippo axis. Hippo axis inhibits the residual oocyte follicles that are there in the ovary are inhibited by the hippo axis. The hippo axis can be, reactivated either by chemicals or by cutting, even a cutting of the ovarian cortex. So the new technique that they are now trying is you go in with a laparoscope, you cut the cortex and re-implant the cortex on the spot in the same setting. So you reactivate the ovary. So you can do GCH PRP injection in one ovary, and in the other ovary you can remove the cortex, put a little, make it into multiple cuts and re-implant the cortex in the same setting back into the ovary to reactivate the ovaries. So the mechanical reactivation is the new concept that is coming in now.
Yeah, this is something new. That's why I want you to elaborate. Thank you.
Thank you, Dr. Sanjeeva Reddy. I think so. It was a great session. Thank you, all of you.
Thank you. I forgot to thank all of Sanjeeva and Kamala Madam and every one of you, all my friends. I have written all the names here. Sanjeeva, Kamala, Kedar, Prakash, of course our President, Kundavi, Sharad, Dhanabhagyam, Jairani, Papa Dasari, Padmaja, Geeta, Vijay Ganesh, and Sati Pillai also I saw there somewhere. So I'm really grateful to all of you. And I remember our conference, the annual conference, Chennai is special for us, and you are always there. And I think, as Prakash said, you are at the forefront. Your society is doing, the local society is doing fantastic work.
Yes, thank you.
Sanjeeva is very active. We all appreciate. He is really stimulating all of us to take part in all conferences.
Sanjeeva is the PRP now of Chennai Society.
Yeah, everyone.
Thank you.
Is reactivation of the old ovaries now.
He is telling
Okay.
I'm old.
No, you are young. We are old.
You're old.
We never get old. Don't worry. Always we are all IVF people are always young. Don't think we are all old.
Yeah. We are younger than the younger people.
Yes.
We'll go to the next session.
Yeah, thank you.
I will introduce the chairperson, Dr. C.V. Kannagi Uttaraj. She is the Director of Thamarai Fertility Services, Coimbatore, Salem, Chennai, Tirupur, Pollachi, Ooty. So many centers. I don't know how one person will be able to control. She is having Thamarai Fertility Center, and she will be organizing every year in Coimbatore nice FORTAG. So we all will be going. Thank you, madam, for that. And she is a very famous speaker. Many national and international forums she will be speaking. And she will very thorough reader. All she will be update. Thank you. Next is Dr. Vijaya Ganesh. She is the committee member of TAPISR. She did her MBBS in MMC, MSc Genetics, Human Genetics in Ramchandra Medical College, and she is doing her PhD. And Dr. Tamil Nadu MGR Medical University was awarded her Best Doctor. Thank you, Dr. Vijaya. And Dr. Kalpana, she is a reproductive medicine specialist from Madurai, South Zone Coordinator in Endometrial Committee 2014-16, Course Director for Postdoctoral Fellowship in Endogynecology, Member of Institutional Ethics and Principal Investigator in Clinical Trials, Organized Secretary, Mother Obstetric Gynec Society Silver Jubilee Conference. She was invited for many conferences, national, and published many papers. And she was also awarded by Dr. MGR Medical University as Best Doctor, Golden Excellence International Award by European Continental University, Medical Excellence Award 2018 from Government of Tamil Nadu, Best Medical Service Award from Madurai District Collector. I asked Dr. Kannagi to introduce Dr. Padmaja Veeramachaneni for her next talk.
Hi, can you hear me? Can you see me and hear me?
Yes.
Yeah. So thanks, Dr. Sanjeeva. It's a pleasure traveling on your webinar cruise every weekend. And as captain of the ship, you guide us very well. And we have new entrants into the cruise every week. And this is a really commendable job you're doing. Please continue. Thank you for taking the effort. My pleasure to introduce Dr. Padmaja Veeramachaneni. I hope I pronounced it right. She's a postgraduate with an FCGP, FMSc, and FMAS and an FICOG degree. She's held several positions as chairperson of APSR chapter, president Vijayawada OBGYN Society, ex-secretary of the APOG Society. And the awards in her basket are the first prize in the IAP quiz at Warangal, Mathur Prize in Physiology, Rama Memorial Gold Medal in OBGYN, Progress 2001 second prize at the quiz, prize in free paper presentation at the 6th APCOG, and I'm sure there's a lot more there. And over to you, Dr. Padmaja. And the topic is very interesting. In fact, I was so curious, I called Dr. Reddy and asked him, which ward are we going to find? Is it the COVID ward or is it the regular OBGYN ward? And here is Padmaja to tell us how to win our medical wars. Over to you, Dr. Padmaja. Good afternoon, everyone. I'm just sharing my screen. When Dr. Sanjeev Reddy had asked me, I very promptly agreed. And then after I've seen the whole program running, I have a very, very hard task to follow. Thank you, sir, and thanks the entire team for the I don't seem to be able to move my slides. One moment. As Dr. Was telling us, can you see my slides?
First, open your.
Yeah, I opened it. It is that tail is.
Sana, can you help her? Sana?
Sure.
Can you help?
So the
Please open your PPT, ma'am.
Yeah, the PPT is open, but it has been open for so long.
Okay,
Can you see anything?
Yes,
Now it is visible.
yes.
Yeah, it's down. Yeah, you're getting it.
Yes.
Yeah.
Put it on slideshow. Yes.
Yeah, you got it. Fine. So among all the warriors that we do see, sometimes we forget that the people who are really fighting are our clients. So I wanted to tell the story. Like you've been hearing so many webinars and about the technologies and about what we are doing. But this is a story from what is happening to our women. So Miss DG, a 25-year-old lady, walked into our clinic on 27th July 2009, a very smiling face. She said, I love children. It's always my dream to have a big family, and I have primary infertility for 3 years because of, I've been married only for 3 years, but because I have a history of irregular cycles and heavy periods and some amount of dysmenorrhea, I started having a checkup fast. So regarding her cycles, she told us she used to bleed for almost 30 days with a variable amount of flow from heavy to normal to spotting to premenstrual spotting. And she has a break of 2 months to 3 months, and then she bleeds again. And with this dysmenorrhea, she has associated GI symptoms, vomitings, increased bowel frequency, and she had used medications to regularize these periods. She is in a non-consanguineous marriage. And then she coolly tells me that she is a known case of congenital heart disease, who had a big ASD, and she underwent this repair around 8 years ago. And because of her dysmenorrhea, heavy menstrual bleeding, she had a checkup quite soon after her, 1 year ago, before she came to me, when she had right side lower abdomen pain, and on a clinical examination, it was thought she could be having a chronic PID or an ectopic, and ectopic was ruled out because the urine pregnancy test was negative. She was given azithromycin, Chimerol 4, Polybion, IV, Zenfloxacin, Metrogyl, Overon. And when the pain did not subside, she underwent an ultrasound. These were done before she had come to me, where there was bilateral ovary showing multiple small follicles, and in the left ovary there was almost 5 centimeter cystic lesion with internally coarse, another lesion of 3 centimeters with thin septae. So it was thought that maybe there is endometriosis, maybe there is a pyosalpinx, and there seemed to be a small fibroid in the uterus. So for this, she underwent laparoscopy, where the uterus showed normal size with the left side endometriotic cyst, left hydrosalpinx that was adherent to the colon, the right tube that was adherent to the pelvic wall. Both ovaries had endometriotic cyst, which was aspirated, cyst wall enucleation was done. And within view of the left side hydrosalpinx, a salpingectomy was done. All the endometriotic spots were ablated.
And because it was already a stage 4, she was given injection leupride, and she went on to, but even after the surgery, she continued to have lots of heavy menstrual bleeding. So she was put on medications. She was given withdrawal with Dufeston, and every time she used to have heavy periods with pain, so she was on painkillers. And at a point of time, they thought maybe there is an element of chronic PID, the most common cause in India being tuberculosis. She underwent, she had ATT for 3 months, and she was on pills. And meanwhile, she was already on injection GnRH analog for 3 months. And recurrent pain, recurrent loose motions, and you can see the number of times the antibiotics were used, IV fluids were used, methoxyprogesterone was used, the painkillers that were given for her GI symptoms. And she had HSG because one of the tubes was taken off. So in that, the other tube was shown to be patent. And with the she also had a family history of diabetes, heavy menstrual bleeding, coronary artery disease. On an examination, her BMI was within normal limits. She had periods, and she was not willing to have an examination. The male partner, non-smoker, non-alcoholic, with a normal BMI, with normal male factor. So at this point of time, when I did her own her ultrasound, it was on the day 28 of her period. And we could see in the right ovary one area suggestive of, because we know that she has endometriosis, we don't expect to find another pathology. There was a 19 mm cyst on the left ovary, there was a 35 mm cyst, and there was no plane of cleavage visible between the uterus, the ovaries, the bowel, so we thought it was a frozen pelvis. And now we had to sit and talk to her. So what are the, we wanted to know the biological, remember this is in 2009. So by then we did not really have very good guidelines. So we did, I thought the biological activity we know by doing a CA-125. The options were because of this, and if there is a high CA-125, we were considering giving GnRH analog, because that was the time where the treatment of endometriosis was getting a pseudomenopause regime, where we thought suppression of the activity and later going in for a gonadotrophin IUI will give us better results. The other option discussed was going ahead for an ART program. But she continued to have heavy menstrual periods, dysmenorrhea, passage of clots, prolonged bleeding. So with that, there was no way we could give her gonadotrophins for induction because of the continuous bleeding she was having. So she was on GnRH analog for 3 cycles along with pills. And if you can see that in August when I saw, the cyst was 35 millimeters. And after 3 months of GnRH analog, when I saw in December, the cyst was still 37 millimeters. There was absolutely no change in the size of the cyst. So, but there was, she continued to have this sort of severe pain. She was given antibiotics, loose motions, and by Feb 2010, we had decided that this sort of conservative management is not going to work out, because we're not seeing, all our management, all our protocols did not seem to be making any difference for her. And by the Feb 2010, the cyst size appeared to be slightly lesser. So she was counseled because of the continuous pain and loose motions and the bowel symptoms. The options are, should we go ahead for a laparoscopy, remove the little stump of the tube on the left side that we could see as a hydrosalpinx, do a right tube delinking, adhesiolysis, remove the endometriotic cyst. And we were suspecting maybe does she have an ovarian abscess, because every month she would have this tenesmus, irritability and all. And because she wanted to know, I used only 3 months of ATTs, what if I have tuberculosis? So we wanted to do even send the tissue for TB PCR. We also had counseled her, do you want to go for IVF? She was not ready for a repeat laparoscopy. The question of the talking about donor oocytes had come up because she was very keen to know, see, I'm suffering so much, you're going to use my genetic material. Will my child, whoever it is, have a similar problem? So we were telling her there will be a higher incidence, but as such, you cannot guarantee that there will be a problem or there will be no problem. So we, after reviewing the whole thing, we thought doing a repeat lap surgery will not be worth it. We did a menstrual blood TB PCR, and we went ahead with a long protocol with using a combination of Rec-FSH, HMG, and as you can see, we had a large number of follicles growing. But in a long protocol, we have absolutely no other option, so we had to give HCG. In spite of so many follicles being there, almost around 30 follicles, we only had 8 oocyte cumulus complexes. We had 6 embryos, and we did a day 3 transfer and froze 3. And we did not have too many hopes, because we know that with large number of follicles, there will be an abnormal endometrium, and she was not willing for a freeze-all. She said, after going through so much, I do want to try. So we froze 3 and did 3 transfers. She did not become pregnant. We planned the FET cycle, but none of those embryos, to our shock, survived the thawing. And we were left with going ahead for a second cycle of long protocol, where we used HMG. She had an OPU. She had 4 grade 1 embryos, and she was not willing to take the chance of freezing. So we did a fresh transfer, and the beta HCG was negative. It took her 2 years to have the courage to come back, and she came back in 2012 for her 3rd cycle, where we started off with a big endometriotic cyst because she was lost to follow-up in the middle. And we had 11 oocyte complexes, 8 ICSI done, 4 fresh transfer done, and she did not conceive. And now was the time to sit and talk to her, because we had 3 cycles with long protocol, and none of them did result in any pregnancy. So what are we going to do? Then the studies were coming then that antagon cycles also was giving us good results. She wanted to try, so we decided for an antagon cycle, and in October 2012 we went ahead with an antagon cycle, and we had 19 oocyte cumulus complexes, 8 fertilized, 4 embryo transfer done, 3 vitrifroze, and she had a beta HCG 2 weeks at 849. She had, right from the day around 5 to 7, from the time she had beta HCG positive, she was continuously having cough, respiratory infection, sort of wheeze, and she had a triplet intrauterine pregnancy which turned to a viable twin. She had threatened abortion, that implantation bleed that was there, and persistent respiratory infection. Sputum culture sensitivity showed Klebsiella. We treated it. Then she had bronchitis, prominent pulmonary lymphadenopathy, MRI test was also done, AFB was checked, and at that point of time, cervical encerclage was done. But unfortunately, at 22 weeks, she went on for a preterm PROM, cervical stitch was cut, and both fetuses were expelled. And 3 days after the fetuses were expelled, her respiratory cough had totally subsided. It was so devastating that she did not have, we had to go through the whole thing. And by then she said she wanted to take a break, and we were also quite relieved. And a scan done there showed that the uterine volume was, we were trying to explore the reason for the PROM. Could we have found anything? And then we found that the uterine volume was very high and we could find adenomyosis. There was endometriotic cyst. So we planned to give at least a GnRH analog depot before we went in for fresh embryo transfer. And because it is an estrogen dependent tumor, she decided, we were exploring alternative medicines, and we decided to try out to see if ormeloxifene, which is a SERM, will help. Meanwhile, she also tried clomiphene induction. These are outside. She had injury, deep vein thrombosis screen. She was given her CA125 at that point was 53, which was within normal limits. October 2013, because she had those embryos that were already frozen, we used them for transfer, and it was a biochemical pregnancy. She went ahead with, she said, I know I will become pregnant again. So we went ahead with the 5th cycle of stimulation, where we had, in an antagon cycle, 29 oocyte complexes aspirated, and 22 of them are from the ovary with the endometriosis. We had 10 ICSI, and to our surprise, she had such a vascular erosion that we could not negotiate the internal loss. After so many embryo transfers in this cycle, when we had great embryos, we could not negotiate it. It was highly vascular, it was bleeding, there was absolutely no way I could enter. So we counseled, froze all the embryos, went in for a cryo-cautery of the ectropion, and then went in for a transfer. But it was only a biochemical pregnancy. Then she went ahead and did diet modification, lifestyle modification, yoga for endometriosis and everything, and came back for her 8th embryo transfer, where she did not conceive. And that was the time where we sat and, after counseling, talked to her about maybe a surrogacy program. So she did go for a surrogacy program. And even for this antagon cycle, you can see the right ovary did not yield. It was very difficult to access. And left ovary, where the endometriotic cysts were there were 18 oocyte cumulus complexes. These we transferred into in 3 occasions into surrogate, and none of them did implant. 2016, this was a year later, she came back with pain abdomen, where we found hydrosalpinx and an ovarian cyst, and we were exploring other medications because she's got to get on with her life. And that is where we decided to use, there were studies telling that cabergoline will work by decreasing the prolactin, inhibiting the vascular growth. Dynofem was just in the market. There were some studies, early studies on Resurrectol, and we had put her on all of them. And when we checked out the ovarian volume before starting treatment of the cyst was it was around 4 centimeters, and after 3 months of use it was still the same. So none of these medications really worked for her. But because we did not have any other options, she continued the same. And there was a progressively increasing size in the endometriomas, and she was having persistent AUB. That was where we had to talk to her. Maybe it is time that we stopped giving you hopes and go for a pan-hysterectomy, but she was not willing. She went in for alternative medications, and she came back to me in 2017 with huge, with adenomyosis, bilateral chocolate cyst with the CA1.
Interrupt just another couple of minutes.
Yeah. And she did not give us consent for hysterectomy unless it is malignancy. And when we did the laparoscopy, we found sigmoid adhesions and an ovarian abscess. The histopath of that showed only endometriosis. A year later, she came back with endometriotic cyst. And then after a year, she underwent panhysterectomy, with a bilateral salpingo-oophorectomy with bladder repair, internal iliac ligation, blood transfusions. And after the surgery, at the vault, we could see an echogenic mass. She was having menopausal symptoms, so we started her on Pibolone. And finally, this June, she is now relatively pain-free, and there is no evidence of endometriosis. So after 6 pickups, 36 embryos, 15 fresh transfers, 7 frozen transfers, 11 embryos, 1 triplet, which led to a PROM, we still were not able to give her a baby. So, and she still comes to me, talks to me, and she is a source of inspiration to all the other people who are coming, telling, don't give up.
Oh, I'm sure, Dr. Padmaja, that is a very big war you have fought.
Yeah.
Thanks for elaborating it and going through us through it. So that gives us confidence to treat more such patients. And any questions at the end, we'll handle at the end.
Yeah. So I wanted to say that, like, no, not only do we encourage the patients, quite a large number of them are a source of inspiration to us to keep going. So they are the real warriors. Thank you.
Oh, that's really the warrior and the war was very well described. And we move over to the next speaker. Dr. Sanjeeva?
Yes, just.
Sir?
You can introduce.
Yes. Good noon all. So thank you, Reddy sir, for regenerating us in the pandemic of COVID. And I would like to thank Tapu sir, Reddy sir, and Kamala ma'am. Now here I take the pleasure to introduce Madam Dr. Shobna Patel. She is the director, Patel Fertility and Research Center. This center is the first fertility center in Karnataka to get national accreditation for the healthcare. It's a recipient of Indiewood Medical Excellence Award, recipient of AHPA Award, and also course coordinator, examiner, fellowship in reproductive medicine. And she is president 2019 to 2021 for Karnataka chapter of ISA, president of Karnataka Society of Obstetric and Gynecology Association, executive committee member, Indian Society of Western Reproduction, and she's a visiting professor, Department of Obstetric Gynecology, JN Medical College, Belgavi. She's a fellow in perinatology, University of Illinois, USA, and president from 2010 to 12, Belgium Obstetric and Gynecology Society. Ma'am, I would like to invite you for this session. It's a right interesting topic.
Good afternoon, everyone. Can you see my slide?
Yes.
First of all, let me congratulate Dr. Sanjeeva Reddy for putting up such a good program, and I think he does a very commendable job. Lots to learn from him. And today what I'm going to speak is nothing related to the management of ERT, something offbeat. I hope all of you will enjoy listening to my lecture. I will start with a small fairy tale, a fairy tale called as Emperor's New Clothes. Once upon a time, there was an emperor. He was very fond of wearing new clothes. He was so fond that every 2 hours in a day, he used to change his attire. And most of the time, he used to be standing in front of the mirror rather than in the court. Then once 2 swindlers came to his court. They pretended to be weavers. They told the king that, they can weave a cloth, such high, good quality cloth, which has good patterns and colors, but also has a remarkable property that where a stupid person or an unintelligent person will not be able to see the cloth. So this really interested the king. He said, oh, it's really good like to have a dress like that. So then this will also help me to differentiate a person who are intelligent and who are not intelligent. So immediately he gave a lot of money, and then he gave gold and he gave silver, and then he told them to, okay, set up the loom. So they set up the loom and they used to work late in the evening. After a few days, the king was very curious to know what was happening, how the work was going on. So he sent his old minister to find out. So the old minister went there, and then he could see nothing on the loom. But he was very scared to come and tell nothing is there on the loom, because he thought people will think that he's stupid. So he came and told the king that the dress is being sewed. It is very good. It's fantastic. So similar thing happened with all the other ministers and other officers who went to see the loom. Finally, the D-Day came and the king had to wear the dress. And the swindlers acted as if they're bringing the dress, and they came and gave the king. But the king could not see anything. He wondered, am I stupid? Am I not able to? Why am I not been able to see the clothes? However, he pretended that he removed his old clothes and he pretended to wear a new cloth, and then he wore that and he went on a procession, and under the canopy, and he went on a procession, and there many people who were standing outside, and they all couldn't see anything, but still they went on praising and saying he's wearing such a wonderful cloth, the color is so good, the flow is so good. Then suddenly one small boy was standing there, and he screamed out. He said, "The emperor has no clothes." So a silence struck, and then everybody realized the truth, how the swindlers had cheated the king. So the moral of the story here is, many of us do pretend just because we want to sound good or look good, or we want to look smarter. So we may pretend that that something is happening, but it may not be really happening. So probably an innocence of a small child is much better than faking anything. So today we are talking the evidence-based medicine in that context. So let us move on. Are we going to practice evidence-based medicine, or is it going to be a practice-based medicine? That's the question. I have a disclaimer. I'm not for or against it, but I'm going to give you facts. It's up to all of you to decide what you want to do. In the spring of 1990 at McMaster's University, there was an young professor called as Gordon Guyette, and he introduced a new concept called as scientific medicine. He implied that the current clinical decisions were less than scientific. Though this was true, it was not accepted by his people, and they showed a cold shoulder to him. He came back in 1992 with another terminology called as evidence-based medicine. And this was based on the groundwork done by David Sackett. What is an EBM? EBM is a novel method of teaching medicine at the bedside using critical appraisal technique. So David Sackett was the father, he's called the father of EBM, and he has done a lot of pioneering work. He's a pioneer in EBM. He was the founder chair of the first ever Department of Clinical Epidemiology and Biostatistics in the world. He made seminal contributions to the way medicine is practiced, and he gave lectures all over the world. His thrust area was designing, conducting of NRCT and reduced bias in clinical research. But David Sackett, when he was a professor for 20 years. When he was a professor, after being as a professor in a medical school for 20 years, he at the end of 20 years, he resigned from his post. He went and joined as a resident in the same medical school. He thought he was not good enough. And one of the famous quote of David Sackett is, "Half of what you learn in medical school will be shown to be either dead wrong or out of date within 5 years of your graduation. The trouble is, nobody can tell you which half." So the most important thing to learn is how to learn on your own. The other fathers of modern clinical epidemiology were R.T. Cochrane and Alvin Feinstein. So we all know about Cochrane and the contribution what he made for in the field of RCTs, and then how the Cochrane library evolved. So in earlier days, it was the medicine which was practiced was called as an authority-based medicine, be it Aristotle or Hippocrates. So there was this terminology, Latin phrase, which was called as an ipsi dixit. That means it's something which was written at the end of the statement which was given by the master. So that means something which cannot be challenged or it cannot be refused. That was an assertion without proof. So nobody can question it, nobody can challenge it. You just have to execute it. That was called as an authority-based medicine. Next, the man being a free thinking man, and he started his practice, and he, based on his own skills, knowledge and experience, he started doing an experience-based medicine. But however, this was not standardized, and the results dependent on the opinion of the single practitioner. Then came the evidence-based medicine. Evidence-based medicine was presumed to be better because it was based on the research, and also it was the people could not use, the doctors cannot use any unnecessary intervention which has not been proved in the medical field, that cannot be used. So it is definitely cost effective. There is a lot of transparency. It was supposed to be presumed to be better. After 1990, the articles on evidence-based medicine just shot up like this. Then came the era of guidelines-based medicine. Now we are in the era of guidelines-based medicine. What are guidelines? Guidelines are systematically developed statements to assist practitioner and the patient decision for specific clinical circumstances. So we have guidelines. Who makes these guidelines? There are a panel of experts who sit together. They may be head of an organization, and they look at all the reviews, article, and meta-analysis, and they come up with some guidelines, and which will help us to manage the patient. You can see here that in last 70 years, there is an uprise in the number of articles on the guidelines. So we are reading more and more guidelines now. So, but what is evidence-based medicine? What did David Sackett say? So, as per the definition given by David Sackett, evidence-based medicine is a systematic approach to clinical problem solving by the integration of best research evidence with clinical expertise and patient value. So it has got three things. One is the research evidence, clinical expertise of the physician, and the patient value. So all three are important here. Is it good? Is it EBM good? Of course it is good. Why? Because you stay current with the latest medical practice, and then it improves the patient care, it improves transparency, and it works. So we are very happy about evidence-based medicine, and we all talk about we are practicing evidence-based medicine. So now we know that this was an article published in 1995, but now we know that we are bombarded with information. Earlier only articles were there, now we are bombarded with social media as well. And the time available to read, according to this journal, it was, for a physician, it is less than 1 hour per week. But the time needed to keep current on general medicine was, the person has to read 19 articles per day, 365 days per year. So obviously we cannot do that. So we have moved on to this Google Scholar, PubMed, and Update, and Cochrane Library. So we have filtered material which is available. So we just have to read the guidelines and follow it accordingly. But EBM has got its dark side too. Let's look at what are the flip sides of EBM. EBM has got a lot of biases. There could be selection bias, there could be statistical bias, there could be publication bias, there could be linguistic bias, commercial bias, and so on. There are a lot of authors, they put vehemently, and they criticized about the evidence-based medicine, and they said that there is a case against the evidence, and also they said there is inadequacy of evidence-based medicine, and there is a movement in crisis. So a lot of articles came like this, and it is broken. That is what the word that was used, evidence-based medicine is broken. And a letter was written, a report was sent to David Sackett telling that evidence-based medicine has been hijacked. So this is what the worry is. Why we are worrying? Because when we are talking about improved patient care, I said about three things. When we are talking about guidelines-based medicine, the individual clinical expertise and the patient values and expectations take a backstage. So which is not really very right. And there is a mismatch between the evidence-based recommendations with reality. We all know that there is a mismatch between evidence-based recommendation that is given and what we practice in the real life. Most clinical trials exclude patients with multi-system or organ disease and other clinical variations, and they are enrolling ideal patients rather than a typical patients what we see. So the science of EBM is highly reliant on consistent, reproducible conditions, but we all know that humans are not consistent, reproducible creatures, be the patients or the practitioners. Some of the evidence may be of the highest quality, but they may not be fit for a particular socio-economic and ethnic group. For example, You can see here that ethnicity as a determinant of ovarian reserve, difference between an Indian and a Spanish woman. Ovarian aging occurs 6 years earlier in an Indian woman as compared to Spanish woman. So obviously ART outcome will be less optimal in Indian women, and we need to change the protocol or change our management based on the woman whom we are treating. Evidence also changes over the time. It's interesting to note here, this is a Cochrane review published in 2000. This is timed intercourse versus IUI with or without ovarian hyperstimulation for subfertility in men. This was published in 2000. And they concluded IUI offers benefit over timed intercourse both in natural cycle and in OI cycle. But in 2007, the same objective done by the same authors, the conclusion was there is insufficient evidence to recommend IUI over TI with or without OI in male subfertility. Company-sponsored articles influence evidence-based medicine. From 2006 through 2014, there has been a decrease in the newly registered NIH funding trials. It's interesting to note that published in JAMA 2015, about 80% of the US clinical trials registered with clinicaltrial.gov are sponsored by industry, whereas only about 20% are funded by the National Institute of Health. So this is changes has been seen from 2006 to 2014. And whenever there is a head-to-head randomized trial, which is if it is mostly industry sponsored, the result is almost always in favor of the industry sponsored. So industry funded trials yield positive results in 96.5% of the cases with an odds ratio of 2.8 with respect to government funded studies. They try to cherry pick the result, or they may suppress all the negative results what has come. Causation and association. We all know that causation and associations are two different things. There could be an association, it could be statistically significant also, but it may not be the causative factor. So we cannot take this together. Even if it is statistically significant, if it is not clinically significant, it doesn't make any difference to us. The wrinkle effect is an example given to this. The hypothesis was people with wrinkles are much more likely to die early. So the result that the conclusion what you can draw is around 6,000 people lose their life every year because we do not have a proper 7-day Botox service in our hospital. This could be the result. Payment to journal editors from companies. We all know that we get a disclaimer from the authors, that there is no interest. But in journal editors, do we have a disclaimer taken from the journal editors? This was a study which was published. It was a retrospective observational study to estimate the financial payment from industry to US journal editors. And the conclusion was industry payment to journal editors are common and they are often large, particularly for certain subspecialties such as gastroenterology, urology, and orthopedics. Now coming to meta-analysis. We all know that we are hearing a lot of meta-analysis, and this is a Stanford professor who has written in 2016 that we have an epidemic of deeply flawed meta-analysis with a number. In the last 20 years, research studies have increased by 50%, whereas meta-analysis have increased by 2,600%. Doing a good RCT is very difficult. If you want to do a study, it is difficult. You have to have a good sample size, you have to work hard, and you have to work on the statistics, you have to get it published in a good paper. It is very, very hard. But doing meta-analysis is not that hard. All you have to do is take some RCTs and then pull them together, put a good statistical application tool to it, and then make a paper and publish it. And what happens in the bargain is, you are not comparing apple with an apple, you are comparing apple with an orange, and which we all know is not right.
Dr. Shobna, I have to interrupt. There's 2 more minutes. You have to finish it by 1:42.
Yeah. Madam, just give me 3 minutes. I'll just go quickly. Yeah. So this is, and to publish any RCT, I told you it's a holy grail, but you can have another option, which is called as pay and publish. And this is a scam which was released by an Indian Express, and which showed a scam of a person who was single person sitting in an office, no peer review, nothing. He is the largest publisher in Bareilly. And there is also difference in the existing guidelines published by different professional bodies. Peer review, this Richard Smith, editor of BMJ for 15 years, he said the peer review is a flawed process at the heart of the science and journals, and we need less research, better research, and research done for the right reason. So, absence of evidence is not evidence of absence. So, are we moving into pro-Christian method of practice? Pro-Christian was a mad bandit who was in the forest, used to abduct everyone who used to pass by, used to tie them into this pro-Christian cot. And if they were smaller than that, used to stretch them. If they were bigger than that, used to amputate them. So finally, nobody survived. So now we are moving on to artificial intelligence in healthcare. So we have guidelines. We feed them into the robot. So we don't have to really need a skilled doctor or an intelligent doctor. We just put the diagnosis. It will tell us what should be done. And we have a protocol. We have a guidelines. And then we go ahead and do it. So if we have to do that, do we have to study anatomy, physiology, and pharmacology, and day and night like this? Do we need to do all these things? This is something which all of us have to think over. So to conclude, I would like to say a good doctor uses both individual clinical expertise and judiciously available external evidence. Neither alone is enough. So when there is evidence that something works, is good, and it benefits the patient, do it. When there is the evidence that something works is harmful and does not benefit the patient, do not do it. If there is insufficient evidence, rely on your individual clinical expertise and be conservative. So this was I'll end my talk with this quote by Marcia Angel, who was an editor of New England Journal of Medicine for almost 20 years. She says, it is simply no longer possible to believe much of the clinical research that is published or to rely on the judgment of trusted physician or authoritative medical guidelines. I take no pleasure in this conclusion, which I have reached slowly and reluctantly over my 2 decades as an editor of the New England Journal of Medicine. Thank you very much.
So excellent presentation, Dr. Shobha, and maybe we should maybe Dr. Reddy sir should invite you next, not in the webinar, in person, and give all your stories. Very nice presentation.
Thank you.
Thank you very much. Thank you very much. Sir, next.
Dr. Kalpana, can I introduce Dr. Sati Pillai?
Yeah, can you hear me, sir?
Yes, yes.
Okay. Thank you for the wonderful opportunity. I'm very happy to be a part of this wonderful ECME with President Izar, Secretary Izar, past President, and Foxy President-elect, and all other eminent personalities. So I've been enjoying all your ECMEs happening on all Sundays. Almost this is a 7th ECME, I think. I would like to congratulate our active secretary, president, and team behind it. So now we have obesity in infertility. Obesity is a very common disorder which can affect even adolescent girls. So it can manifest. Sorry. So it can
okay. So it can proceed.
So it can manifest as menstrual irregularities or infertility or sometimes metabolic disorders. So we have Dr. Sati M. Pillai to talk on obesity in infertility. Madam is graduated from Trivandrum Medical College, and she did her DGO MD in Vadilal Sharabai Medical College, Gujarat, and she is the Chief Infertility Specialist, Samad Hospital, Trivandrum, Kollam, Kerala since 1989. Her areas of interest are infertility, ART, minimally invasive surgery, and ultrasonography. So her present position is President Izar Kerala Chapter 16 to 18, editor of Izar Kerala Chapter Journal 2016, Vice President Izar Kerala Chapter 14 to 16. And her achievements are, she delivered her first test tube baby, South Kerala's first test tube baby in 2000. South Kerala's first blastocyst baby in 2001, world's third oldest post-menopausal delivery at the age of 62, and first surrogacy baby of Kerala. And her hospital is the first NABH accredited IVF hospital, ISAR accredited IVF hospital, ICMR enrolled IVF hospital, FOGSI recognized training center. Over to you, madam.
Thank you. Thank you, Kalpana. Let me also thank Dr. Sanjeev Reddy and all the office bearers of TAPISAR for giving me this opportunity to talk. I will not waste time because we are running short of time. The topic is obesity and fertility. And can you hear me?
Yes, yes.
Okay. The topic is obesity and fertility. And as an introduction, let me tell you that obesity is a worldwide health problem, and actually it is an epidemic, especially among the young. And it increases the morbidity and mortality due to several diseases, cardiovascular disease, diabetes, hypertension, malignancy, and also it has a negative effect on reproduction. And India, even though it is one of the only a developing country, it has the third highest number of obese people after US and China. And to define obesity, it is an excess storage of triglycerides in the adipose cells. It is more in females than in males, probably because of the lack of activity among females and the tendency to eat more among females. And the WHO has classified obesity according to BMI, waist circumference, and waist hip ratio. Below 18.5 is underweight, and above 25 and above is overweight. Up to 29.9 is overweight, and above 30 is equal to or above 30 is obese. And coming to waist circumference, if a man has for men, the waist circumference is equal to or more than 90, and for women, equal to or more than 80. Waist hip ratio, for males, it is equal to or more than 0.9, and for females, equal to or more than 0.8. But India has brought out, the ICMR has brought out another parameter to assess obesity in India. According to the ICMR, obesity is classified into overweight, generalized obesity, abdominal obesity, isolated generalized obesity, isolated abdominal obesity, and combined obesity. Here, overweight is normal is 18 to 22.9, 23 and above is overweight, up to 24.9. From 25 onwards, BMI 25. Sorry, can you hear me?
Yes, yes, madam. You can proceed.
Equal to or more than 25 is generalized obesity. Abdominal obesity is when the waist circumference is equal to or more than 90 for men, 90 centimeter for men, and equal to or more than 80 centimeter for women. Then obesity can also be classified as isolated generalized obesity. Here the BMI will be more than 25, but the waist circumference of these people will be below the obesity cutoff. And again in abdominal obesity, the BMI will be within normal limits, but the waist circumference will be more than the cutoff for obese women. And combined obesity when all these parameters are increased. It is more prevalent in urban population naturally because of mechanized transport and more of fast food, sitting at home, lack of exercise, viewing television, and all these reasons are causing obesity more in the urban population. There are two types of adipose tissue, brown adipose tissue and white adipose tissue. Their functions are antagonistic. Now coming to the brown adipose tissue, which is the good adipose tissue, it is highly vascularized and innervated. There are high quantities of brown adipose tissue in adults, who have a lower body weight. With increasing age, the fat decreases and body weight increases. That is, the white adipose tissue increases. The purpose of the brown tissue is dissipation of energy through burning of fatty acids, because it contains free fatty acids, and the aim is to maintain the body temperature. Exercising will convert white adipose tissue into the metabolically active brown adipose tissue. Coming to the white adipose tissue, it is the largest reservoir of energy, is a thermal insulator, as well as it is gives a cushion effect to the body and especially the internal organs. It is a major endocrine organ which stores excess energy as triglycerides. It is usually found around the hips, thighs, buttocks, breast, abdomen, or inside the abdomen in the gonads, mesentery, omentum, perirenal areas, and also in the pericardial area. Increased visceral white adipose tissue is associated with several diseases like metabolic syndrome and reproductive failures and malignancies, different types of malignancies in the esophagus, again in the gallbladder, pancreas, and colon. It also causes sleep apnea. Then adipose tissue. Adipokines are cytokines which are released by the white adipose tissue, and they have important roles in the regulation of certain physiological processes like reproduction, immune response, glucose and lipid metabolism. An excess or deficiency of white adipose tissue can result in sexual maturation dysfunction, pubertal disorders, and fertility disorders. Coming to male infertility, obesity has independent adverse effect on semen parameters. Both low and high BMI, that is below 19 and over 30, are associated with a reduction in the testicular volume and reduced semen quality. A decline in the ejaculate volume with increasing BMI and waist circumference negatively impacts total sperm count. As the weight increases, the testosterone level decreases, and this causes a poor sperm parameters and reduced fertility. And remember that the odds of infertility increases by 10% for every 9 kilos a man is overweight. And the effect of obesity on male fertility is multifactorial and modulated by genes, endocrine and genetic, endocrine and environmental influences. Endocrine disruptors are also responsible partly for this pandemic obesity. Here you can see that obesity, how it causes subfertility. Obesity can be caused by genetic reasons also, and once obese, it causes physical disorders, hormonal disorders, and which lead to erectile dysfunction, altered semen parameters, and subfertility. Impaired spermatogenesis in the male, obesity causes an alteration in semen parameters in so many different categories of the semen. That is sperm concentration, total sperm count, total motile sperm count, as well as total progressive motile count, sperm morphology, and again it also increases DNA fragmentation. But these are the authors who found this, who published this, but other studies show conflicting results. Increased male BMI causes a reduced plasma concentration of SHBH both and testosterone, both total as well as free testosterone. It again causes an alteration in the FSH-LH ratio and inhibin. That is, it causes a decrease in the FSH-LH ratio and inhibin B, whereas it increases plasma estradiol level. This alteration in the hormonal parameters causes a disruption in the negative feedback loop with the HPG, hypothalamo-pituitary gonadal axis, and it causes a defect in the Sertoli cell function. A targeted disruption of FSH signals and receptors leads to aberrant gametogenesis and hormone imbalance. In obese men, the estrone and estradiol levels are increased. This is because of the peripheral conversion of androgens to estrogens. Endogenous opioids also play a role in morbidly obese women. Or morbidly obese men, and resulting in hypogonadotropic hypogonadism. A decrease in the androgen level is proportional to the degree of obesity. Kisspeptin. Kisspeptin is a peptide which is released by the hypothalamus. This acts directly on the GnRH neurons and helps and controls the release of GnRH hormones. And this again causes controls the pulsatility and frequency of LH secretion. In obese men, what happens is that estrogen has a negative effect on kisspeptin, and because of that, the LH release, the pulsatility and the frequency of LH release is totally altered, and this causes a decrease in the testosterone level in the Leydig cells. Then the effects of obesity are causes insulin resistance. Sex hormone binding globulin is reduced due to the increased insulin level. The insulin level is increased because of the insulin resistance caused by the obesity. The low testosterone level occurs due to independent effect of testosterone production also on the testosterone production. And sleep apnea occurs, sleep fragmentation disrupts the nocturnal testosterone. Total testosterone and erectile dysfunction is also reduced. It is proportional to the degree of sleep apnea. This causes associated reduced sexual quality of life. Then again, it causes metabolic syndrome, and this has been associated with hypogonadotropic erectile dysfunction, and there's a prevalence increases with age. Hyperinsulinemia and hyperglycemia has an inhibitory effect on the quality and quantity of the testosterone level and semen parameters. Then again, there's a thermal effect on spermatogenesis. Spermatogenesis is highly sensitive to heat. Normally, the testis functions at 34 to 35 degrees centigrade, but because of the scrotal obesity and the suprapubic obesity and the thigh fat, this contributes to the elevated temperature, resulting in reduced sperm function, motility, and increased sperm DNA fragmentation. And again, it increases the sperm oxidative stress. Surgical removal of the scrotal fat has been recommended as one of the treatment methods to improve sperm parameters. Then leptin is an adipokine which is released by the white adipose tissue. It influences appetite and acts on the reproductive system. Leptin acts centrally at the hypothalamus to regulate GnRH neuronal activity. An increase in the leptin increases in obese males because of leptin resistance, contributing to decreased production of testosterone from the Leydig cells. Infertile obese males are leptin resistant. And these infertile obese males also have high levels of homocysteine and low levels of vitamin D. These are also associated with obesity. Leading to altered semen parameters. And sperm DNA fragmentation, increase in the BMI causes an increase in the semen macrophage activation, causes increase in the oxidative stress. Hence, sperm motility decreases and sperm DNA fragmentation increases with decreased acrosome reaction and decreased embryo implantation rates following IVF. And obesity also causes epididymitis because of the physical trauma caused by the increased deposition of fat in the thighs and scrotum. Besides that, the redundant lumps of fat in the suprapubic and inner thighs can cause a mechanical inflammation to the scrotal contents by shearing and rubbing forces. Obesity affects sperm maturation and fertilization and also causes blockage of the epididymal ducts by scarring. Because of the inflammation, there is scarring in the epididymis and causing block in the epididymal ducts and cyst formation. And bilateral epididymitis can occur because of the trauma. Then psychological impact on sexuality is that it can lower sexual satisfaction, sexual enjoyment, sexual desire. There's a difficulty with sexual performance, and so they try to avoid sexual encounters, and again it causes erectile dysfunction. The sexual dysfunction in obese men is related to the hypogonadism and elevated levels of pro-inflammatory cytokines. Here you can see that obesity, how it causes scrotal hyperthermia, chronic epidemics because of the fat deposition, erectile dysfunction, sleep apnea. And in the systemic part, it causes an increase, causes both leptin and insulin resistance. And there is increased adipocytes, which cause increased aromatization, conversion of testosterone to estrogen, which occurs in the adipocytes. And pro-inflammatory cytokines and reactive oxygen species are also released by the adipocytes, which cause an increase in the sperm DNA fragmentation. And again, it causes sperm epigenetic changes. The effects of maternal obesity, which cause epigenetic changes in the sperm parameters, are in testicular development are the male gonads produce testosterone in the intrauterine period, crucial for the formation of the male genital to move from the abdomen into the scrotal sac. At this time, when there is exposure to high estrogenic level from the mother or from environmental disruptive factors, this causes reproductive disorders in the male child, and this is known as testicular dysgenesis syndrome. And this can all in later life, this causes lower sperm count, hypospadias, and even cryptorchidism. That is, the movement from the abdomen into the scrotum does not occur. And again, later in life, testicular cancers. Then coming to female infertility. Female fertility and obese, and sorry, I'll come to the management of the male obese patient. Diet and exercise induced weight loss is associated with an increase in the total sperm count, semen volume, testosterone levels, and normal sperm morphology. The diet should include correction of micronutrient deficiencies, high intake of omega-3 fatty acids, antioxidants, and phytochemicals. Bariatric surgery improves hormone parameters, but it may not improve semen parameters. Aromatase inhibitors have been suggested as treatment, especially what is given is anastrozole, 1 milligram daily. It is given for even for 1 year, 1 milligram daily. The mechanism of action is to prevent the hyperestrogenism by blocking aromatase enzyme and preventing the conversion of testosterone to estrogen. Metformin also may help in obese males with type 2 diabetes, and but the effect is inconsistent. Coming to the female infertility, obese women are 3 times at risk of infertility than a non-obese woman. In the presence of irregular cycles, the woman can be associated with oligoanovulation. When the woman has irregular cycles, she also has oligoanovulation. She can also have anovulation with regular cycles. Here again, she can have probability of pregnancy is reduced by 5% for every BMI unit that exceeds 29 kilogram per meter square. So with regular cycles, she can also have anovulation. She can have a release of oocytes which are a reduced fertilization potential. She can also have endometrial abnormalities which will decrease the implantation rate. The underlying mechanism which causes this is insulin resistance. Here again, she is hyperandrogenic and leptin resistance, causing increased leptin levels. The hyperinsulinemia and insulin resistance are the underlying cause that leads to obesity, followed by hyperandrogenemia and alteration in steroidogenesis. Insulin causes hyperandrogenemia by different mechanisms. One is it directly stimulates the theca cells to cause androgens. Then again, it acts through the IGF-1 receptor, which induces androgen production from the theca, interstitial, and stromal cells. Insulin can bind to IGF-1 receptor as well as its own, and there again it decreases the production of IGF-1 binding protein in the liver, thereby increasing the IGF-1 level in the blood. It decreases SHBG production from the liver, thereby increasing the free testosterone level. Here you can see that the apple type of obesity seen in women are typical of polycystic ovaries. Here you can see that this obesity causes systemic diseases like hypertension, cancer, heart disease, dementia, insulin resistance, lipid problems, non-alcoholic fatty liver disease, and type 2 diabetes, and also fertility problems like polycystic ovary syndrome. Studies show that there is an increased prevalence of miscarriage in obese women. This is controversial, but some studies say that miscarriage rates are increased both in natural and assisted conception cycles. Belver et al. Found a rise in spontaneous miscarriage in patients treated by ART, including embryo transfers using donor oocytes. So this shows that the obesity affects even the donor eggs. The risk of miscarriage was 38.1% in obese women, whereas 13.1% in women with normal BMI. McVally et al. Found a higher risk of early, late, and recurrent miscarriage in the obese group. Obesity can cause miscarriages even of euploid embryos. Again, it was found by Landry et al. So earlier, Belver has said that it causes miscarriage even of donor oocytes.
Sorry to interrupt, madam. You have 2 more minutes to conclude your talk.
Okay, I'll finish. Obesity in early childhood causes altered reproductive function in adulthood. It causes infertility through impaired ovarian follicular development, qualitative and quantitative development of the oocyte. It hinders with fertilization, embryo development, as well as implantation. So the impact of obesity on ART is, as you see, you can see that the gonadotropin requirement is increased for ART cycles. The response to stimulation is poor, oocyte number will be less, and the quality will be poor. With poor oocyte quality may or may not be poor. Studies show different controversial results. Fertilization is decreased, and the embryo quality has been found to be poor in certain studies. Cycle cancellation and OHSS, there is insufficient evidence. Pregnancy rate is reduced and miscarriage rate is increased. And again, in the live birth rate, there is insufficient evidence. So benefits of weight loss are weight loss, even by 5 to 10% among overweight women, improves endocrine parameters. Weight loss causes a decrease in the free testosterone and lowers fasting insulin level and increases frequency of ovulation. There's a significant reduction in central fat deposition in 11%, causes decreased secretion of LH and return of normal menstrual cycle in 4 out of 5 women. So the management is essentially weight loss, either by life modification, dietary restriction, physical activity, pharmacotherapy, and bariatric surgery. Diet programs show poor results. They are not suitable for women who want to conceive soon because of aging. Only 15% can sustain weight loss successfully. Maintenance of reduced weight is critical for reduced complications during pregnancy and birth, and for reduction in cardiovascular and diabetic morbidity. Rapid weight reduction is not good. Metformin does not affect menstrual frequency or weight loss, but it causes a fall in the total testosterone and waist circumference. Orlistat helps in weight loss. Postponing fertility treatment is not good because female aging will again affect the oocyte quality. There is limited data suggesting improved reproductive function following bariatric surgery. Surgical intervention is warranted to prevent potential adverse outcomes of pregnancy in obese women, but it is the last line of treatment, and after bariatric surgery, the lady should conceive only after 12 to 24 months. To conclude, overweight and obese men have been shown to have 50% higher chance of having fertility problems for every 3 kilo per meter square increase in the man's BMI. The couples have 12% more likely chance to be infertile. Etiology is multifactorial, as I have already mentioned. Obesity causes altered semen parameters such as decreased sperm concentration, abnormal morphology, and compromised chromatin integrity and abnormal motility. I have already mentioned all that. And in case of women, obese women have a higher prevalence of infertility, maternal morbidity, mortality, and fetal anomalies. Weight loss improves natural fertility, and conception rate is also improved with weight loss. And weight loss is the most cost-effective treatment. But as I mentioned earlier, you cannot wait for a long time for the woman to reduce weight because of the age. The success of ART in obese women is significantly reduced when compared with non-obese women. Thank you.
Thank you, madam, for the talk. Thank you, madam, for the excellent talk. It was wonderfully explained about the impacts of obesity on male and female infertility. Thank you once again.
Actually, நம்ம செக்ஷனே யாரும் கிடையாது.
The session is open for questioning. Just see. Dr. Kannagi is not there. She went for one emergency. Vijaya and Kalpana, you can ask the question.
See, there is a question for Dr. Padmaja. Is it 5 centimeter endometrioma in an unmarried girl wants to defer surgery till marriage? Can she be managed on Dinoges or surgery should be insisted? This is from Dr. Vani.
Yeah. Dr. Vani, we are tending to see a larger number of young people with endometriosis because I also believe that obesity, lifestyle, endocrine disrupting substances are all playing havoc. The thing is, what did she present for? If there is severe pain, then no medication is going to make her pain-free. So she will need a lap endometriotic cystectomy. But what we need to remember is if we don't do anything, 70% will recur within 6 months. So what we need to do is put her on a medication later on also. And because we are putting them on Dynogest and the other medication, whatever we are giving, pills, whatever you're giving, tell them it has to be long term. Endometriosis will, as long as there is a menstrual cycle, there is going to be a recurrence of endometriosis. And one of the things that is not really well explored, and as Dr. Shobna said, we don't have much evidence because we don't have much publications, is the role of injection Depo-Provera. I have used personally in a series of cases, and I believe that is a cheap alternative. Because she is unmarried, maybe we can use it for a year or two and stop before she plans her marriage. If anyone else has anything to say.
There is one more question by Dr. Kedar Ganla. Just somebody asked, apart from T-shaped uterus and low uterine volume, can a pre-pregnant report of small uterine size can cause RPL? He has given low volume cavity can be treated with metroplasty. He's not there, just his answer I am telling, he is put up in here. Any other questions? Kalpana or Vijaya, you can ask them.
So if this question is answered, I don't know. We are doing ultrasound guided embryo biopsy for genetic studies in case of early abortions to avoid maternal contamination. Comments, please. This is, I don't know if this question is answered. This is question.
Restrict to these 3 speakers.
Okay, sir. I think there is one.
If I can answer that,
Yes.
ultrasound guided embryo biopsy. The thing is, when we are taking out the products of gestation, we should remember that we, even when you are using an ultrasound, you are still going to get maternal tissue decidua coming in. It is very difficult, even with a transabdominal ultrasound, to go and pick up just the embryo and come out. Especially in cases which are having an anomalous uterus, previous sections, we've done ultrasound guided, but practically speaking, you're not going to get only the embryonic tissue. You're going to get decidual matter contamination also.
Sir, I have a small clarification from Madam Dr. Sati. Is there any use of myo-inositol in male infertility? Myo-inositol.
Inositol, as Dr. Rishikesh Pai has mentioned, is just an empirical treatment for male infertility. Only an empirical treatment, you can give it. That is all.
We have another question. to practice evidence-based medicine, it will take more time and it should be authorized. It's from Dr. Kallappa.
True.
Shobana, you was okay.
Yeah. I think I mean, I agree with that. That's what I said. There should be a balance of both. That's why I showed that pic, like, we should have a balance of both evidence-based medicine and your practical skill. That is the right balance. That's the right balance.
So this is another question. How far and how much is PGS results reliable? Can we reliably base our decision to choose and transfer based on it? This is from Dr. Lakshmi. Who can answer this question?
There is no doubt in the results, but there are many papers now. After biopsy, it is proved it is not the euploid. Still, they transferred the embryos. Almost 40% pregnancy rate is there. That's why we cannot advise for everyone. Only recurrent pregnancy loss or known persons with some problems for the parents. There we can go and do like that. Or if it is coming as recurrent pregnancy, recurrent implantation failure, there you can advise. Not for everyone.
Sir, I was at ISHRE last year when I attended one of these exclusive early pregnancy one. In that, what was proven was that the embryos, quite a large number of time, they're mosaics. Not all cells are aneuploid. So the aneuploid cells are being pushed into the trophectoderm, which is in the placenta, and they're being excluded. They're replaced by normal growing cells, and these abnormal cells were undergoing more apoptosis. So these are the limitations of that.
Yes, there is auto correction also will occur after transfer. That's why this we are getting. I'm telling you, like up to 40% pregnancy rate, and that also normal.
Yeah.
That babies are normal. That's what.
Can I ask you a doubt?
Yes, ma'am.
No, that is to Dr. Padmaja.
Sir, Adam.
We're talking about the girl, unmarried girl, chocolate cyst, endometriosis.
Yeah.
After corrective surgery, can you give them OC pills continuously, 3 months, 4 months?
Yeah. What I believe, madam, we don't have, like endometriosis also is not just one uniform disease, because there are so many pathologies that are underlying it. Some of them have more of progesterone resistance. Some of them have more of inflammatory background. Some of them have more of angiogenesis. So if there is a lot of progesterone resistance, our pills are also going to give it estrogen. So we need to watch them very, very carefully. And I think further studies will tell. We can give OCs, but even on OCs, we cannot tell them that it will be inhibited. Because oral contraceptive pills are also having 25 or 35 micrograms of estrogen. So even that can cause. If she is continuing to have heavy menstrual periods on OCs, then that is not the ideal for her. Giving a pure progesterone is better.
But what I meant is, will this be a cheaper option if you give them continuously without a break for 3 months, 4 months? Like I think it was available sequential pill.
Yes, that's what I'm telling, madam. The thing is, we should prevent endometrial shedding. So we should not have a real endometrial growth. If this continuous pill is able to maintain a thin endometrium, then it works. So we should monitor.
Thank you. As the time is getting delayed, we'll stop with the discussion. There will be a lot of questions will be there.
Thank you, sir.
First of all, I would like to thank all the state chairpersons of ISAR, Dr. Mamata Dayal from Telangana, Dr. Padmaja from AP, Dr. Kamala Selvaraj from Tamil Nadu and Pondicherry, Dr. Sati M. Pillai from Kerala, Dr. Shobana Patel from Karnataka for accepting our invitation to join together for this webinar and make it a grand success. We have 750 plus registrants on a Sunday, in spite of other webinars are going. Thank you very much, madam.
It is your credit.
In addition, other speakers like Prakash Trivedi, President is Sir, Dr. Hishkesh Pai, past President is Sir, Dr. Kedar Ganla, Secretary General is Sir, and Special NOIT, Dr. Shantakumari, President-elect Foxy, and also she is Secretary to Telangana chapter of ISAR. I thank them all.